Yes, good morning everyone again, and thank you for coming here and joining us today. We are in the second day of our Health and Education Symposium, and we are waiting for some attendees to come in. And of course, now at 9 o'clock already, the students are in the class that are watching us here, or we can say that they are attending us face to face with their professors in the class. So they are watching from there. And for today, yesterday we had open speeches of the professor, but today we already invited our International Academic Relations Coordinator, Assistant Professor Dr. Osman Gültekin, who will be with us. Maybe Professor would like to add something, as we have today some special guests like Sanja KUPESIC Professor is already here, that we will start with the Professor. Yes, Osman, Hoca.
Thank you very much, Dr. Atta. Dear professors and faculty members, I would like to welcome you all to this conference again on the second day of the event. I hope this academic event will be a great success. And I witnessed the diligent work of Dr. Atta and our medicine faculty for the preparation of this event. And we are very glad that it is going excellent so far. At Istanbul Aydın University and for our International Relations Directorate, we give special importance to this kind of important events. These events make our university truly international, and also we perceive great benefit from sharing information and learning from great international scholars like yourselves from different parts of the world. And today's subject is of great importance, not only in our countries, but also all over the world. Health and education are the two most important areas that literally save people's lives. Today, I see many great academicians with us. We are very happy to see that. And I also would like to inform you that in Istanbul Aydın University, we are very open to international academic cooperation. If you don't have an academic cooperation agreement with your university yet, we are very interested in making one for sending and receiving students and academicians to and from your universities. And without further ado, I wish you a very successful event in the rest of the conference. And thank you for being with us today. My best regards to all participants.
Thank you very much, Professor, for being with us today and sharing your time with us. You supported all the time. We worked together, because without your help and your team, we couldn't find already a lot of speakers, esteemed speakers that are today with us. And I think that the students are lucky today with us because they will listen. I listened to the Sanja KUPESIC in the jury panel. I had the chance to meet with her today. And today we are going to start with the professor. But before starting, I would like to give a little bit information, introduction of our professor, just for 5 minutes, and then I will give the time to the professor. The first speaker today will be Professor Sanja KUPESIC PLAVSIC. And when I give an information, we can see that the professor, after completed the Faculty of Medicine in 1987 in University of Zagreb, Croatia, she continued her studies in the obstetrics and gynecology in the same university, where the subspecialty of the professor especially is on the field of reproductive endocrinology and infertility. Of course, if I miss something, I would like from professor to add if there is any information more. Now the professor, since 2013, she is working as a professor in obstetrics and gynecology and radiology department in the Texas Health Science Center, El Paso, Texas, USA University. And beside her academic career, the professor also holds an associate dean position at the Faculty of Development since 2015 at the same university. The research expertise of the professor, especially for the students that are watching from the class there, I would like to mention that if they are interested in the future, because we have the Faculty of Medicine student, the professor's expertise is on the reproductive endocrinology, infertility, ultrasound and color Doppler, medical education, and faculty development especially. And when we check about the resource productivity, we can have a look that The professor has an over of 6,000 of the citation in this regard in the field that she is working on. And I would like to thank again for the professor that she's sharing her valuable time with us, especially in the late time that she is being now in the USA. And I would like to say, welcome again to our symposium, Professor KUPESIC. So now is your time. You can share your, I'm stopping my sharing. And now you can share your presentation. Welcome again, Professor.
Thank you so much for so many nice words and precision in your presentation. I only wish my mother was there.
Thank you.
So thank you so much. Thank you so much. So welcome from United States. It's 2:30 in the morning. And I'm currently welcoming you from the city that never sleeps, from New York City, where I'm on my vacation. And thank you for giving me the privilege to talk about revolutionizing healthcare education. We hope for a healthier tomorrow. Well, I will just need to go further. Okay, here I am. So the objectives of my presentation today will be to address the importance of reshaping the healthcare education, but also to provide the understandings of the advantages and disadvantages or challenges of current healthcare education models, and also together to anticipate the healthcare changes and emphasize which direction we are going to take in healthcare education to maintain high quality, efficiency, and accessibility of healthcare. And also to demonstrate the potential of new and emerging health education methodologies and tools for future learners, but also for professionals. So let us now, as I told you, I'm greeting you from the city that never sleeps, and I'm very glad that I will share my educational experience, but also my life experience, and also the experience from my last 2 weeks. Actually, I started my vacation in Quebec City, where I was invited to present at Grand Rounds at their university. And then I thought, you know, it will be great to not to fly back home, but also to take instead a cruise. So I planned a cruise from Quebec City through Newfoundland, New Nova Scotia, and New England to New York. And everything looked fine because I was about to start on September 13th and arrived in New York on September 20th. But then I realized then on my way and in the middle of my cruise, there will be a hurricane. There will be a Hurricane Lee that is expected to landfall on September 16, 17, just exactly at the place where I was expected to be. So definitely, I didn't like to cancel my cruise because I think that travel is like endless university, and experience and travel, as Euripides says, are as education in themselves. So I decided to continue my travel and to have full confidence in the decision of the captain and the cruise members. So we had a great start. We started in Saguenay, and I got beautiful images, photos for you because I'm the imager. I'm expert in ultrasound, and everything looked fine. It was just before the storm. And then the clouds started to appear. It was very dramatic. So our captain made a very smart decision. He actually landed us into the Corner Brook in Newfoundland on this beautiful island. And instead of course, cruising, we were hiding here in the bay, and we had chance to explore the inside of the island by a very narrow railway that they have there. And it was wonderful because we escaped the storm. And the day after the storm, we just appeared in the beautiful New Nova Scotia in Halifax, which is a very picturesque place. And why I'm just mentioning all of this? Because I think that our captain showed the qualities of good leader. And I hope that all of us educators should be excellent leaders. We should be knowledgeable. We should have qualities of strategic and critical thinking, especially nowadays when we are facing revolutionizing changes in healthcare education. We have to be, and the captain had to be, self-aware, open-minded, creative and flexible to allow us to enjoy cruise, but without endangering us. And he had to be responsible and dependable with good communication skills. So to inform us what he's going to do and why he's making certain decisions. And therefore, I thought by sharing this kind of experience may be a good introduction to what I expected us, the medical educators, the healthcare educators, to be in this on this crossroads of healthcare education. So here I am, I appear in New York on September 20th, and this is our ship. So we had great time, but also I learned a lot because the travel is, as Euripides says, a great way to educate yourself and to widen your perspectives. Because I think that by leaving your country, you will learn most about your country. And as I had chance, by living in Croatia, I had chance to learn most about Croatia because I see all the benefits and all the advantages of my country, as well as with university. You have to share your experience. You have to leave your university. You have to leave your home to visit other places, to see and to learn more about yourself and your home and your university. That's why I really appreciate everything that you are doing at Aden University, because giving opportunity for this international experiences is great for your students, is great for your faculty and for their professional development. So I'll just focus now on one objective, because I think that first objective that we have to somehow study is the changes in healthcare education and changes in healthcare itself. So what are the expected changes in healthcare? I believe that new technologies such as artificial intelligence, augmented reality, surgical navigation, telementoring, that will all enable procedures to shift from academic medical centers to community centers. This is very important because academic medical centers are tertiary institutions and they have all kinds of experts. And many times they are not covering wide pathology that students and residents have to be exposed to learn the art of medicine. So I think that we will be facing just to this transfer of care to the community centers. Second, we are going to focus more on prevention and treatment. For example, the patients in the future are going to have integrated healthcare records with portals, and they're going to guide themselves on weight management, on physical activity, healthy diet. So they are going to be dedicated to preventive care, self-care. The third anticipated change is implementation of virtual monitoring. I believe that our patients are going to have all these wearable devices like virtual hypertension, diabetes monitoring that will require also professional development of completely new types of healthcare forces. For example, mid-level providers, health coaches, and so on. So we are facing really changes in healthcare providing services. What is also very important is that in the future, there will be a merge of health and social care. So that means that instead of treatment and focusing on treatment itself and the diagnosis, most likely we will have to create a very robust primary and community care where we are going to have multidisciplinary teams that are going to help to coordinate all the healthcare related issues, mostly relying on prevention as stated before. So definitely all these anticipated changes in healthcare are going to open the need for professional development in areas such as telemedicine, clinical informatics, healthcare, data analysis, and personalized medicine and genomics. And that's why I'm very glad that I see in your program exactly that you are addressing all these issues that are very, very important in current and future healthcare education. So definitely what is also very important, that technology will enable rapid dissemination of innovation. Currently, we have a very linear dissemination of innovation, starting from preclinical research, clinical research, and then implementation, like in drug discovery. I believe that all these advantages of new era in healthcare and healthcare education will enable very rapid dissemination of knowledge. So in my presentation now, I will focus on the current landscape of healthcare education. Then I will discuss the challenges in today's healthcare education. What is the vision for the future? I like to discuss also some innovative strategies in healthcare education. And then I would like to conclude with the path forward. Let us now start with the first topic, the current landscape of healthcare education. I would like to discuss first the key components and characteristics of modern healthcare education and how it has evolved during the last few decades. We all agree that key components of modern healthcare education are that we are delivering evidence-based curriculum, a lot of clinical simulation, interprofessional education. Everything is focused towards patient-centered training with a lot of technological integration. We are providing continuous assessment and feedback to our learners. We are focusing on lifelong learning, a lot of community engagement, trying to give global healthcare perspective. That's what we are going to do today. And also, of course, always allowing students to be a part of our research initiatives. This is an example of a very integrated and complicated curriculum in my medical school, Paul Foster School of Medicine at Texas Tech University. As you can see, in the first 2 years, we have very integrated curriculum. And instead of traditional subjects like biochemistry, anatomy, physiology, we have scientific principles of medicine. So all our knowledge is integrated in this SPM, Scientific Principles of Medicine course, where we actually teach our students based on clinical presentation. All basic science knowledge and clinical knowledge is packed for them. And every week they're exposed to 1 or 2 most common clinical presentations the patients come in with. Then we have another course, which is medical skills, that is integrated. So every week, the students in pre-clerkship years are going to have 2 hours of medical skills, where they're exposed to interviews with standardized patients and all low fidelity, high fidelity mannequins and high technology in medical simulation. And then we have also society, community, and the individual, where they're exposed to the community and public health topics. What is also very important is that every week they have 2 hours discussion about ethics and ethical topics in medicine. So this is an example of a very integrated pre-clerkship curriculum. In our clinical years, we have blocks. So we are blocking family medicine with surgery, internal medicine with psychiatry, obstetrics and gynecology with pediatrics. And we have integrated sessions that are helping them to integrate the knowledge. What is important is that in the 4th year, we have a boot camp during which in clinical simulation, entirely clinical simulation, we are actually going through this entrustable professional activities, making sure that our students are going to actually be a very functional residents once they engage in their postgraduate education. Continuously, we are assessing their knowledge. Every week, they have formative exam, every single week. And they have exams in each and every courses that I mentioned. At the end of every year, in year 1 and 2, they have comprehensive end-of-year exam. And then they have, of course, OSCEs. OSCEs are happening at the end of every unit, but also they have end-of-year OSCEs. That will enable them to pass successfully, hopefully, step 1 by the end of 2nd year and step 2 by the end of the 4th year. So they should be fully prepared to engage in their residential education. So how our curriculum and education has somehow evolved over the last decades. First of all, we are transforming passive learning, and we have replaced it completely with active learning. That means that we have, of course, problem-based education, case studies, a lot of simulations, as you had a chance to see. We have also, we are conducting very interactive workshops, and of course, emphasizing critical thinking of our learners. We are integrating technology, so we have e-learning platforms, virtual reality simulations. We are applying telemedicine and use of many mobile applications, making it very adaptive and interactive. And here you see some academic applications that are supported in our university. We have Alentra and Kinos as e-learning platforms. We have Cultura. We are, of course, serving our students via Qualtrics. We are testing them using Respondus, and for feedback and continuous assessment, we are using a lot everywhere. And these are the applications our students have access to. We are also focusing on interprofessional education. So collaboration, working in multi-member teams is a very important part of our education and our effort. And they are learning together, they are learning and somehow studying with each other and growing with each other during this educational experience. We also emphasize the importance of globalization in healthcare. We are organizing international rotations, many global health courses and projects, and that will hopefully allow them to be prepared to work in diverse settings and to address healthcare disparities. There is also a very important switch to the integration of new research findings into the curricula, and we are, of course, emphasizing the importance of evidence-based practice. Of course, it is important that they are ethically and culturally competent, that they are taking care of their well-being and mental health, that we are preventing their burnout, stress, and mental health challenges. And of course, we like them to be a part of continuous professional development, and we are encouraging their participation in continuous medical education activities. Because it is very important that by the end of their medical studies, they understand that formal education should not be on the way of their learning experience. So they have to be encouraged to actually continuously professionally develop. We are definitely engaged in a patient-centered curriculum where standardized patients and real patients are the center and the focus of our educational efforts. And of course, we are teaching them there's these soft skills, the communication skills, shared decision-making, and understanding the patient's experience of their illness. It is very important that they are an integral part of the community. So we have a strong emphasis on community health, on public health and preventive medicine. And also they are very engaged in community outreach and health promotion activities like vaccination during the COVID crisis and so on. So as you can see, the components of our curriculum are heavily actually relying on technology, on interprofessional education, on continuous medical education, including global health ethics and communication skills. So what are the challenges of this healthcare education efforts? The challenges are that we are rapidly advancing in technology, and it is outpacing the curriculum updates. So our curriculum not only that needs to be updated yearly, it is updated weekly. Of course, this is all increasing the cost of healthcare education. And there's very difficult to reach the balance between the theory and hands-on clinical experience. Therefore, we need more and more interdisciplinary collaboration, and we need to address the diverse learning preferences of our learners. This is very important because every learner has different pace, has different learning style, and we need to address that. But the problem is that we have overloaded curriculum. So we need to educate our learners how to find the appropriate information, but also with this overloaded curriculum, how to maintain their well-being and mental health, and also, of course, how to address evolving health concerns and to expose our learners to longitudinal patient-centered care and experience. And this is the most difficult thing, because longitudinal experience is really, really tough, especially with this limited clinical exposure. So we do have, and we do experience clinical placement shortages. This is a major problem because theory can easily be actually presented on very attractive e-learning platforms, but the problem is practice in real clinical environment. And of course, the problem is standardizing education across institutions and keeping up with regulatory and accreditation challenges. This is very, very difficult in the United States of America. I learned that this is also difficult and more difficult in Europe, and I believe also in your country. And therefore, we need continuous faculty development. Therefore, this is my passion. I'm very dedicated to faculty development because I think that this is the core of changes in healthcare education. So what is the vision of the future? Definitely, we are going to utilize digital platforms. I think that in the future, medical education is going to be run from a very comprehensive digital platform, and it will be the same for all medical schools in the United States. What is going to be different is going to be hands-on activities in simulation environment and in clinical environment. We are going to utilize virtual reality, artificial intelligence, augmented reality. We are going to have other advanced technologies that are going to enhance learning experience. But what will be important is to diagnose student learning process, their specific needs, continuously assess them, and to customize their content. Then we are going to definitely have a need for telehealth training. We have to equip students with their necessary skills to provide telehealth services. And we have shortages of faculty who are performing qualified telehealth services nowadays. And this is very, very important thing to address. We have also to take the holistic approach to our patients. We have to practice preventive medicine and holistic approach to patient care. We also need to put emphasis on lifelong learning, interprofessional collaboration, diverse and inclusive education, focusing on mental health, and we have to run sustainable healthcare education, which means that we have to know our students how to address the challenges like climate change and how it impacts human health. And of course, we are going to practice global health curriculum. We have to provide active and experiential learning, which means that we have to shift from passive face-to-face and online lectures to active problem-based learning, case-based sessions, simulations, and world clinical experience. Of course, our students have to be exposed to culture of research, and they have to be a part of our projects and contribute to advancing medical sciences. Always having patients as partners, we have to be enrolled in education process of our patients. We have to ensure our students understand the patient's perspective, and we have to prioritize throughout every single moment of our education, the patient-centered care. The students have to be a part of community, and they have to learn medicine in the context of their community-specific health needs. This is important because the theoretical knowledge may be the same, but the community needs will be different for every medical school, for every university. And of course, everything has to be founded on ethics, and we are now exposed to significant changes in application of medical technologies and treatments, but we have to place a strong emphasis on medical ethics, ensuring that the students are going to be prepared for the complex decisions that they will face in future. And doing all of this, we have to be flexible and adaptable. We have to design the curriculum that can be rapidly adapted in response to emerging healthcare challenges like in COVID pandemics. There will be more in the future, and we have to be prepared for that. And what is very important, what is at the core of everything, is to continuously upskill our faculty members, our staff members, to ensure that they're equipped with modern teaching methodologies and that they're updated on the latest healthcare advancement. This is very important. So our curriculum should be changed day by day, week by week. It shouldn't be only updated once a year. It is a continuous evolution. So what are the innovative strategies that we already implement, and we are going to have more of those in the future? First of all is simulation-based training. Simulation-based training, leveraging low fidelity, high fidelity mannequins, virtual reality, augmented reality, hands-on training in controlled environment without risk to real patients. This is very, very important. And that's why from day one of medical school, we expose our students to standardized patients in medical skill environment. Second thing is competency-based education. So we like our students to master specific skills and competencies. So not only theoretical knowledge. We like to prepare them for real-world clinical situations where they are going to be able to find the relevant information on the palm of their hands using different applications. That's what is important, not memorization that commonly is the basis for traditional curriculum. We also are really engaging in flipped classroom approaches, because when you meet with your students, you have to meet with them with a good reason. That means that you are going to solve some problems, you're going to have discussions, you're going to have very open arena with your learners, because they have right to ask the questions, and you have to explore the answers. This is very important, exploration of answers, not memorization. And we have to focus our education on hands-on activities. And the problem that we have now is that we have less and less of the faculty who can really do bedside teaching, because they don't feel comfortable in doing this kind of teaching, because it is a very slippery terrain. We also need healthcare educators that are very well trained in interprofessional education. This is the future, because we are working as multidisciplinary teams, and we like our students to be exposed to nursing students, to pharmacy students, to dental medicine students, because they have learned together. They have to reflect team-based care in the real world through simulation activities, but also on the wards and in ambulatory care. So what is also important is to use standardized patients in the education process, because that gives students insight into the patient experiences, concerns, and needs. Currently, we have 50 standardized patients in our medical skills center who are interacting with our students. We have standardized patients for pediatrics. So we have children who act as standardized patients, to patients in the third age who are actually part-time employees of our university and are very busy in our medical clinical simulation center. We focus on soft skills, so we try to really develop this empathy and teamwork and leadership skills for our students, because I believe that every nurse, every physician have to be leaders with the qualities that we enlisted in the beginning of my presentation. I believe that artificial intelligence is very important, and we are going to have more and more artificial intelligence-driven platforms that will adjust the content based on learning progress, and they're going to provide targeted resources and feedback. I had a discussion with the director of innovation at one of the biggest e-learning platforms, Blackboard, and he told me that the initial data assessing the artificial intelligence-driven platform are actually very encouraging. He mentioned that there is a 30% improvement in students' success on the exams after the artificial intelligence was introduced for adjusting the content and for diagnosing the students' knowledge and somehow diversifying the content according to the students' need. And of course, global health experience is very important because we live nowadays in a global village. The students have to participate in international rotations and projects to be exposed to diverse healthcare settings and challenges, because this is the world that they're going to practice in. And we have to integrate continuous feedback. And this real-time feedback systems are very, very important because we have immediate insight into the student's performance and the areas of improvement, because not every student have the same needs. Not every student has the same learning style, or they need different types of approach in sharing for their improvement in healthcare, whatever the field of study is. They also have to be involved in project-based learning. This is very, very important. And of course, we have to expose them in telehealth training. And this is something that we have some telehealth platforms in medical skills. And we see that this really helps to cover the gaps in this area. As I stated before, community health needs are different in your country, are different in mine, and we have always to teach medicine in the context of the healthcare promotion in your community. Research opportunities are very important. Our students do have mandatory student research project that they enroll in the first year of their studies, and they have to complete it by the time of their graduation. And this is a very important part of their commitment. So what is the path forward? How we should actually move forward in healthcare education? First of all, we have to emphasize the adaptability for continuous improvement. We have to encourage research and development in healthcare education. And we have to collaborate with tech industries, because we have to incorporate these cutting-edge tools. This is very important. So as my captain has made changes to our crews, I expect us to also navigate the changes successfully together, depending on this very, very evident revolution in digitalization and e-learning. So definitely we have to introduce modular and highly integrated curriculum. That type of curriculum can be frequently updated. We have to prioritize lifelong learning skills. We have to teach students not to memorize the facts, but to keep updating their knowledge continuously through their careers. So this is a need. They have to realize that there is a need for their professional development. We also have to embrace the digital tools that allow real-time update of course material. So we have to ensure that students are always learning the most current information. When we meet with our students, we tell them that on the first day, that by the end of their medical studies, the facts, the medical knowledge will change for 50%. So that means that 50% of the current medical knowledge will become obsolete by the end of their studies, by their graduation. So that's why there is a continuous need for improvement and for updating the course material. So also we have to encourage research in healthcare education. And I think that it is very hard to do medical education research. So we have to establish dedicated departments or units within our educational institutions to be dedicated to healthcare education. We have to encourage collaboration between educators and researchers and students to find out which educational methods work and which educational methods do not work for them. We have to assess continuously the efficacy of our educational efforts. And we have to disseminate findings. Why I should be repeating something that doesn't work in other institutions? So that means that we have to collaborate globally to benefit from the advancement in healthcare education. We have to forge partnership with academic institutions, but also technical startups or giants of technology. This is very important because we have to stay updated with emerging technology trends, and we have to assess the potential application in healthcare education. We shouldn't be resisting to this revolution. We should be somehow sailing with it. We have to adopt it, and we have to use it for the benefit of our learners and our students. Because if our captain saw the hurricane is coming, so what we might have done, we may cancel the trip, but we should not cancel the evolving medical education. We have to develop pilot programs to test new technologies. We have to gather the feedback, and then not only feedback by educators, but big feedback by students. That's we are doing continuous surveying of our students by the end of every session, because we have to adjust the tools accordingly before the widespread implementation of this new technology. So what are the advantages of this revolution that we are facing? First of all, there's a personalization. As we are going to have personalization of our healthcare, we are going to have personalization of healthcare education. We are going to in the direction of automatic instantaneous feedback. This is very, very important. So based on the results of the assessment, we are going to provide actually a material that is appropriate for the specific learner. What is important is that this type of automated assessment is lacking the bias. It is more objective. And also, this kind of education is going to remain up to date with the latest knowledge, which means that it is going to be updated daily. And it will lead eventually to the cost reduction, which is also very important. Simulation and virtual reality, the artificially intelligence-powered simulations are going to allow students to practice diagnostic and surgical procedures, interact with patients. Instead of standardized patients, we have already avatars, and they're going to practice their diagnostic skills in a risk-free setting that will prepare them better for real-time situations. And it is very important that it will increase their self-confidence before they are really confronting the critical situation in their clinical practice. And also, data analysis and diagnosis is very important, because we like our students to be exposed to analysis of complex data in radiology imaging, helping them to make accurate diagnosis and treatment decisions, to be somehow aware of algorithmic learning, which is important, and pattern recognition. So that will help them, especially in certain areas of studies and integration of their clinical knowledge. Another thing is that artificial intelligence can help us to find relevant research papers, textbook chapters, online resources for medical students that will enable them to stay up to date with their latest medical knowledge. So we shouldn't be resisting this high technology in healthcare education. And of course, it can track students' progress, identify the errors they're struggling in, and provide them instantaneous feedback on their success. What is good for us is that artificial intelligence may really streamline our administrative tasks. It may help us with scheduling. You see how complex is our highly integrated curriculum. So we need help with scheduling, because the schedule has to be updated also every day. It helps us with grading. It helps us with managing student records, and allows educators to be focused on teaching and mentoring, which is basically our primary role. So AI-driven collaboration tools will facilitate remote learning. So our students are going to be exposed to expertise, to telehealth education, which is very important, because they can connect with experts that may not be available in their community centers in the future. So this is very important, that we are not going to have geographical barriers anymore. And we have to benefit as educators and as learners, and get used to it, to use the expertise that is available in other institutions in your country, but also across the world. And of course, continuous medical education is important because artificial intelligence can find, for professionals, can identify the courses that are relevant for your specialty and for your professional development. Always we have, of course, to think about ethical considerations. We have to pay attention to privacy and be responsible in the use of high technology and handle it responsibly and ethically. But the challenge, of course, is the lack of human contact, because we have to find the appropriate balance. So our students are going to be exposed to high-end technology, but we have to actually use our time wisely for the skills that they have to learn in real clinical environment. We have to coordinate on-site and bedside education very creatively, and we have to supervise and regulate the new advancement in healthcare education. So we have to teach our learners about the benefits of artificial intelligence and the appearing technology. We have to teach them that it is very useful, for example, in medical imaging analysis. Screening mammography, for example, today is using artificial intelligence. It is not done manually anymore. We are using artificial intelligence for robotic surgery, for personalized medicine, for disease diagnosis and treatment. We have algorithms that already are introduced in our healthcare system, health medical care records. This is very important. So our students or residents cannot progress without actually entering the information about medication to assess actually the drug interaction, for example. We have already using data analytics and management that is helping us with clinical workflows and also hospital management and optimization. So there is a lot of place where this artificial intelligence and high-end technology can be introduced, and our students should be aware of that. So definitely we have to become aware of the intelligent use of artificial intelligence and technology. So it will help us to cut down the administrative tasks, which is important for healthcare providers, but also healthcare educators, which will prevent their actually burnout. We think that the artificial intelligence we have to be aware of its benefit, but also of its challenges, and we have to define and keep to the best practice standards continuously. That being said, I think that the real voyage of discovery consists not in seeking new landscapes, but in having new eyes. I think that we have really to be open to new challenges in healthcare education, to new technology, and we have to sail with it. We should not be resisting it. And that being said, I'm really grateful for this opportunity to share my experience, my life experience, my educational experience. I used those references for preparation of this presentation, and I'm very thankful for your attention, and I'm open to any questions you may have to discuss the benefits and challenges of revolutionizing healthcare education that is in front of us. Thank you so much.
Thank you, Professor KUPESIC, so much for such a detailed and with a full field information with this presentation. You mentioned everything. I think that even the questions that are already sent to me by some students, you already answered in your presentation. But again, I'm asking to my students and to the attendants here, the professors, even our other speakers are here already, if they have any question related with the presentation. So I'm waiting for just some minutes. You can write in the chat box the question. Until we wait from the chat box, we can check one of the questions that is from the students. Okay, there is one question here. Thank you very much, Professor. My question is, how can healthcare education adapt to the increasing demand of telehealth and telemedicine services, ensuring that students are proficient in virtual care delivery? You can check in the chat box already, it's here written.
Yeah, so I think that, and that's one of the challenges that I mentioned, because we do have very limited number of telehealth providers. And in our country, in United States, actually, you have to have, it's a very complicated licensing procedure. So you have to have the license in the state. As you know, we have our licensure is actually provided for practice in every state, and we have 50 states. So in order to provide telehealth, you have to have the license in the state that's where you are practicing, but also in the state that you are reading for. So that's something that is very challenging, especially for such a big country, to use and utilize the resources efficiently. We do have telehealth platforms for education and clinical simulation and skills. And that's something that we are using. We actually have this very robust telehealth clinical simulation in our clinical simulation center. And that's how we actually introduce our students to this topic. But talking about the benefits and ability to practice with a physician in different states and actually attend their telehealth sessions, I think it's a challenge, and we have to find out how to simplify it and how to really benefit from it in the future.
Thank you for your reply, Professor. And due to the time, I'm continuing quickly with the next question, which comes from our Dean of the Faculty of Health Sciences of our university. And the professor says that, thank you very much. Is primary healthcare and public healthcare ready for artificial intelligence even in the USA? It's another question. What do you think about that?
Well, it's such a new technology, and I think that we really don't have the answer to that question yet. What I see that initially we were all resisting to the idea that artificial intelligence will become a part of healthcare education. But I think that we should not resist. It is already there, and it has to remain. But we have just to really educate our healthcare providers at every single level, from primary care to academic institutions, how to use it. As I mentioned, we have to teach our students about the benefits of exposure to artificial intelligence, but also I think that we have to really develop sessions for faculty development and professional development. So we are all aligning our efforts to provide the best educational and addressing healthcare needs of our patients, but also healthcare education needs for our students and residents at every level, from primary care to academic institutions. And that's why I think that academic institutions and universities have to take this responsibility to extend their services to primary care and to educate physicians in these areas, in ambulatory care, to actually adopt new technology. I think this is the responsibility of academic centers and universities to make sure that they are prepared and ready to utilize it.
Exactly. Ayşegül Hoca is already here, I think. And one more. What is your vision regarding managing patients through conversation in television without medical education? It's a little bit a different question here.
Engaging in?
What is your vision regarding managing patients through conversation in television without medical education, examination?
Well, this is something that is really, this is hard because it has so many implications also in terms of liability, you know. So there are certain specialties that really can work. Telehealth is, like in radiology, is definitely there, and I think that especially the use of all these advantages that we have and advances that we have in imaging and artificial intelligence and technology that is applied to this specialty. For internal medicine, even for family medicine, it has a lot of challenges. So first of all, I think it's these wearable devices that I mentioned may be a great complement to this. So if you have a patient that is, for example, having a wearable device to control his hypertension, then I think that with appropriate interpretation of the findings, you have a good basis to actually provide the consultation to this patient. But we have to be very careful, and we have to work and regulate the healthcare telehealth services very, very wisely to prevent suing process, to prevent all the issues that may face healthcare providers of the future.
Thank you, Professor. You give a lot of answers about the question. Of course, there are a lot of questions that come from the students, but due to the time, I could not ask them now. But I just would say to them that if they are interested in much more details, they can send a message to you, I think, if they would like to know about the better medical education and the challenges in this area. So we would like to thank you so much for sharing your time, especially now it's a very late day in New York now that you are already present, and of course you are in vacation now. So we thanks a lot for being here with us, and hope we are going to see next time face-to-face here in Turkey.
Always. Your beautiful town is, your magic town is somehow always in our mind and in best memories. So thank you so much for this opportunity to share my experience. And I love to be again in your beautiful country and your magic city. Thank you so much, and have a great and successful day and conference. Thank you.
Thank you, Professor. We are honored to have you here. Thank you again.
Bye-bye.
Bye-bye. We thank Professor a lot for sharing the information with us. And now, due to the time, because the Professor Atta's patience is very important for us. But before starting with the Professor, I would like to share a very short information about the Professor before starting. To all of our students. The next speaker today is going to be Professor Komal Atta, and the professor already, in fact, is working now as an academic staff in her university in Pakistan. The professor graduated from the biological sciences in 2005 in the Pakistan. That already earned the GCE A level. And after that, the professor completed the medicine and surgery, in fact, which means the Bachelor of Medicine and Surgery in the Shifa Tamer Milliyet University, Pakistan in 2010. Professor already continued a master's degree in the physiology in the University of Agriculture in Pakistan and medical education in the University of Lahore in Pakistan again. As we check in the academic career, Professor works for 3 years in the University of Faisalabad, Pakistan as a senior demonstrator, and now she is already working an assistant professor currently since 2018 in the University of Faisalabad in Pakistan in the physiology department. And besides the academic career, Professor already holds a head and a director position in the Department of Medical Education since 2021 at the same university. The research expertise of the professor is already shown in gamification, curriculum, physiology, and of course, if I miss something, I would like from the professor to add here, and during the presentation, she is going to mention in details. When we check the Professor Atta, we see that it has an overall citation 143 and has a distinction of being the only Pakistani doctor to be featured as an invited author on both the Harvard Medical School community blog of Harvard University, as well as Nature Cares part of the Nature journals with an impact factor approximately 50 points. So I would like to thank a lot for being here, Professor Atta, and welcome to our symposium again. So now is your time. I'm stopping my sharing, Professor. I made you a co-host, so welcome again to our symposium.
Thank you very much. I'm very happy to be here. Let me just share my screen.
Yes, Professor.
Okay, is the screen visible?
Is visible and is it full screen? Is everything clear and okay? Thank you.
Okay, thank you. So thank you so much for the wonderful introduction. And I'm really, really happy and really honored that the Istanbul Aydın University invited us to this wonderful symposium. And congratulations on your 20 years. You've already introduced me. My name is Komal. I am an assistant professor of physiology, and now I have shifted to full-time to medical education. I work as a director of medical education at the Medical College of the University of Faisalabad, that is known as University Medical and Dental College. I am also an associate fellow for the Association for Medical Education in Europe. And one of my main research topics or things that I work on is the curriculum, which we will be discussing today. So today, the topic that I have decided to talk about, which will shape the future learning, as is the target of the symposium, is how medical education and pandemic preparedness will be used by curriculum design in medical education. So curriculum design for disaster and pandemic management. Now, if you see the word pandemic, for most of us, the first thing that comes to our mind is the COVID-19 issue that happened very recently. It's defined as a widespread occurrence of infectious disease over a whole country or a part of the world at a particular time. And obviously, like we witnessed in the COVID time, it has a complete dishevel of everything, from your social interactions to your medical facilities to your education. So it's a time of complete uproar and complete disarrangement in all areas of life. Similarly, if we talk about a natural disaster, so a natural disaster can be an event like a flood, an earthquake, or a hurricane that causes great damage and loss to infrastructure, to lives, to social activity. You can recognize this picture behind from the earthquake that happened in Turkey. We are also in solidarity and in our thoughts are the people of Morocco who have just faced an earthquake very recently. So, like the previous professor mentioned, that climate change is a reality, and as we move ahead, disasters and pandemics, the frequency keeps on increasing and they will keep on coming forward. So it's imperative that as medical educators, as health science experts, as clinicians and physicians and teachers, we have to include these things and be prepared to have these discussions formally as part of our curricula so that our students are well prepared. Now, why do we need pandemic or disaster preparedness as part of the curriculum? Research suggests that education is one of the worst hit sectors in case of disasters and pandemics because our focus is on rehabilitation. It is obviously on life management, on saving, on protection of infrastructures, which should be there rightly so. But during that time, what happens is that we often overlook the dilemmas of the students, of their parents, if they've had any loss of life, if they've had any loss of infrastructure, if they've had any sort of psychological damage due to whatever has happened. So that is often overlooked, and we continue in our system, which we modify from time to time. For example, in the COVID pandemic, we saw that there was an instant modification to online learning in most parts of the world. We did an instant jump, even in Pakistan. Our online learning policies were formulated during and after that time. So that was very overwhelming for the student body, for the majority of the faculty, for our trainees, for our healthcare medical students who are working as house officers or as interns. So that's why it's very important that we need to have this as a component of the formal curriculum. Now, what I will be discussing is about a model that I have just formulated recently. It is under publication now. You don't need to have a set form of curriculum to introduce that. So if you have an integrated curriculum, you can make it a part of that. If you have a traditional curriculum, if you have a systems-based curriculum, if you have a problem-based curriculum, it should be integrated in all of those. Before I start with the model, it is very important that we consider the main stakeholder in everything that we work for, which is the student involved in that curricular activity. So with that in mind, we move forward towards whatever we're going to be discussing. Students will have these questions, according to research we conducted in Pakistan, that at times when disasters or pandemics hit, as you all know, Pakistan is a region which, like Turkey, has suffered from drastic earthquakes. We are facing the aftermath of a huge flood last year. Apart from that, we have been hit worse by the COVID pandemic. We also have other issues going on which classify as problems and as disasters, which might not be natural, but they might be man-made, like war, like political instability. So these are questions which students face, and I'm sure that the students in the audience will also relate to them. That if my medical school closes for a few months, what happens? What is the policy? How am I going to proceed? How am I going to be graded? If the building collapses, what will happen? After that, where are we going to go? How are we going to practice rotations? What hospital are we going to be allocated to? If families and friends are affected, but our studies are resumed shortly, how do we deal with that? If we cannot interact face-to-face, if there is social distancing, what will we do? How will we be assessed? How will we move forward? If we are made first responders in teams for disaster management or for pandemic management, are we well equipped or are we prepared to move forward? And finally, how will I be assessed if there is something which keeps me away from the college, keeps me away from the curriculum, does not let me have sessions that are with the facilitators? How will I be assessed? So these are all the questions that students carry in their mind at such points in time, which need to be addressed by medical educationists, by professionals. And for that, we have to move forward. So moving towards my own context, I belong to Pakistan. Pakistan is a rich, diverse region with mountains and coastal areas, much like Turkey. We have had our share of natural disasters over the last 10 years. There was a huge earthquake in Kashmir, which resulted in lots of infrastructure and life loss all over the country. Aftershocks were almost witnessed for 6 months. You can see over here on the left side, there are images from the earthquake. In the center, if you see, these are images from the monsoon floodings from last year. So this is a beautiful area in Pakistan called Saba, and it was totally disrupted. I'm sorry, I'll move back to the slide. It was totally disrupted, and you can only see a body of water. So an area full of lights was completely destroyed, and we have a lot of students from that area, and they were affected during this time. They had no internet connection. We could not imply online learning. Infrastructure lines were destroyed. Then we have some political upheavals going on even right now, and at other points in the country, we have had wars with our neighbors. So we belong to a region where natural disasters, man-made issues, and pandemics have all hit us. Keeping all of that in mind, at UMDC, the University of Faisalabad, we decided for the last 2 years to plan a contingency curriculum for our students in a model which is known as CARE. So keeping in view the PRET model by the WHO, which says that we have to monitor preparedness for all different sorts of diseases that we think may turn into pandemic in our areas. We started with the identification of the issues. So this is just an example of how far the world has gone after COVID-19 in identifying, according to WHO, the preparedness for respiratory pathogens. So we are prepared to deal with the disease, but are we prepared to deal with the curriculum? Have we made changes enough that we know the plan B or the plan B for our students? So for that, we have been working on it for some time. We consulted literature from nearby areas, including Turkey, who also has done a lot of work in replacement and recuperation of your students, particularly after the earthquake. So the model we have come up with is known as the CARE model. That is curriculum adaptation and response for emergencies. So this model is an acronym where C stands for curriculum assessment and adjustment, A is for adaptable learning methods, R is for resource allocation, and E is for emergency drills and simulation. We felt that this would be a flexible and a way that we are carrying forward and that others would also be able to use if they want. So moving on to the first step, curriculum assessment and adjustment. The first thing that anybody needs to do, whether you are in an area of the world which is affected by natural disasters or pandemics or so, is to conduct a current curriculum review. So you have to assess the existing medical education curriculum. Currently, in our region, we have 2 medical curricula going on parallel. We have an integrated curriculum which has just started for our new entrants, that is the first year. And we have a systems-based traditional curriculum that moves on from second year to final year. So we had to review both the curriculums, and we had to identify areas that need adaptation in emergency situations. So what can those areas be? You have to come down to a contingency plan to include the bare necessities. You have to exclude areas which you think might not be a necessity or need to know at that particular time. For example, you might cut short the curriculum out of certain minor areas. You might cut short the curriculum out of some formulations and some things in biochemistry, out of some portions of forensic medicine, out of some elaborate portions of physiology, and you might dedicate more time to things which might be happening. For example, the floods in Pakistan over the last 2 years, we have a lot of cases of gastrointestinal diseases, a lot of cases of respiratory disorders because of the stagnant water. Children have been drinking that water because in some areas they were not able to get fresh water supply for a few days. And after that, they had a lot of respiratory, a lot of gastrointestinal problems. So that becomes a core area because we have a lot of patient flow from them. So we have to focus more on that as compared to, let's say, zoonotic diseases or diseases that right now might not be part of the pandemic or the natural disaster that comes. So out of all of your objectives, you have to be very targeted. Identify the nice to know and must know objectives of your curriculum. There are always some which are just adjunct, which you may learn later or which you may do by self-directed learning. Stick to only those that you have to impart to your students and focus only on the most important and urgent. And more importantly, we have to align our assessment only with those. So during the COVID pandemic, we found ourselves shrinking curricula because we went online. And in our region, there is a lot of accessibility issue. Not all areas of Pakistan get equal internet facility. We had students who could not come online, so we had another contingency plan for them. If they could come for with safety measures, we would allow them to sit in the computer labs at social distancing so that they could come and learn from here. Otherwise, we had also developed mechanisms such as making CDs or making notes and posting them to areas where students were not able to even reach Faisalabad, where I am. So all of these things can only be done if you have your curriculum to the bare necessities at such a time. For that, advanced planning is obviously needed. You have to have a contingency curriculum that in case any such thing happens, these are the things which I will be including and so will be excluded. So core competencies need to be defined for emergency situations. These may include skills related to infection control, which we already have a module in our curriculum for. Skills related to disaster management. You may choose to have a module to teach your students first aid from the beginning of medical college. Depending on the facilities you have, it can be on simulations, you can teach them BLS, crisis communication. All these things should be part of the core competencies of your curricula. You should have knowledge and imparted about commonest disease spreading as a result of the disaster. So we have to understand that we have to make obviously the geography of your nation is very important when it comes to this. So you have to understand that context is always the king, and according to your context, you have to have core competencies to prepare for emergency situations. Then we come to assessment and adjustment, which is probably the most tricky part that we are facing and we have faced for some time. So make sure that there is some part of your curriculum which has some blank spaces for remediation, for recuperation, for revision in case there is a blockade, in case there is a emergency situation where you cannot continue the studies for a month or so. or you have to have some portion ready to actually remediate that, or you have to have policies to send things for self-directed learning to your students or online learning to be flexible in remediating. So you should always have a flexible curriculum design. The last speaker spoke beautifully about this, about how you can have flexibility in your curriculum, how you can have different things happening. So we need that for emergency preparedness. We need our curriculum to be flexible. We need it to be in such a way that moving its pieces, as I show in the background of puzzle, is easy for us. The A stands for adaptable learning methods. So the first thing is obviously that we would like to have more active learning. We would like to have case-based learning, simulations, virtual scenarios. But then the question that we ask in context of different areas is, how much can you do? Do you have a well-trained faculty who can provide enough case scenarios which are effective for online learning? Do you have a simulation center where you can entertain your students, or do you have software where they can learn from their homes? Do you have the expertise to create virtual scenarios? So out of all of these, we plan whichever one we can use the most. For example, our faculty is very well equipped with case-based learning and simulation centers. So they make cases, and that is what we did in the COVID pandemic. That is what we did for some of our students who could not reach the university during the flooding. So we would be going online and sending case-based scenarios using virtual scenarios. However, again, because of bandwidth considerations in Pakistan, you can't go with a lot of very high technology simulation exercises. So you have to understand that when we adapt, we have to see how much we can do. For example, in Istanbul, you might have a better equipped simulation centers, or you might have more internet bandwidth. So you can go with more advances, just like the Professor states about the things they are doing there. Now, here is an example of our contingency rotation plan, which we used for the clinical years during COVID-19. So we divided the rotations into 3 portions. There was the red zone, the orange zone, and the green zone. In the red zone, we were not having any rotations at all. So this was the time when the COVID pandemic had hit maximum. So we did not have any rotations at all. And we promoted online education, online simulations, and telehealth in the areas where we had people trained. So we had telehealth in radiology mostly, we had telehealth in ENT, we had telehealth in dermatology. But we do not have equipped telehealth centers for the rest of our rotations. And also in Pakistan, the laws for telehealth are not exactly very well established. So we have to make sure that we are running according to policy when we go towards major areas such as medicine and surgery. That is still working area we have. So we have not progressed a lot in that. Then there was times when we had the orange zone, where what we did was we did 2-week rotations for students in simulation labs or online with simulations, and 2-week on-ground rotations. So they were alternating. However, the number of students was decreased so that we could manage their PPE and we could manage their safety and their safe distancing. And then when times of the COVID pandemic were thought to be better, things were moving towards a normal, we shifted back to the green schedule. So we keep this contingency rotation for pandemics. We also have a similar plan for disasters. We have students who cannot reach, or in case there is some sort of political upheaval or some sort of earthquake or natural problem in our own area, we tend to follow this plan for the rotations. Now, moving on to more things in the adaptable learning methods. In remote learning, it's important to see how you can integrate your best technology. And even more important than that is to see that your students can access your educational content when they are in remote areas. So students living in plain lands and big cities in Pakistan generally do not have a big issue with this. Because Faisalabad is a plain land, it is an industrial area. We had most students who could access the online classes through Moodle or Google Classroom platforms, and it went smoothly for them. However, we did develop a contingency plan for students from the northern areas or areas where we know that bandwidth is very low, or where they can only use a 3G or 4G plan, or areas where they cannot use a plan. So plan B was that we created very simple notes and very simple exercises for students who had low bandwidth. We created things that could easily be played, videos which could be in very short bursts, content which was having less graphics, that could easily be played over a mobile internet data. For students who did not have that facility, we ensured that in case they had a nearby area where they could go and access the internet, well and good. Otherwise, they were mailed the content in hard copies, or they were asked to cooperate with the other classes, their mentors, or their faculty through telephonic communication. So during the COVID time and also during the floods, we tried our best to reach out to everyone. But because of resource constraints in the country, it does become difficult at times. So that moves on to R in the care model, that is resource allocation. In the beginning of your curriculum, if you are a dean or if you are an authority at your institution, there should be a resource allocated for emergency preparedness. So this should have some portion for faculty training, for simulation, and for using technology. And secondly, in resource allocation, the most important thing is interprofessional collaboration, where you are working with the healthcare institutions, with WHO, with your government agencies to know whether there is a pandemic alert, whether there is a flood alert, whether something is happening in the region, so that you can shift your resources towards a more emergency situation and come into a higher alert. The last portion of the model stresses on emergency drills and simulation. So we have incorporated emergency situation simulation exercises into the curriculum. I have read in literature, these are also done in Turkey. These mimic real life scenarios and help students practice under pressure. In Pakistan, because of the diversity of issues we have drills for students in case of a threat of a terrorist attack, in case of a threat of a blast, in case of an earthquake, because Faisalabad comes in that region. Which areas of the university are safe, from where will you be going out, what will you be doing? And we tell them or simulate flood-related issues and problems and diseases, so that our medical students are trained in case they are from those areas, that they can provide first contact to anyone nearby who is affected. Now, this is the contingency plan for pandemics. I'll be going through this very briefly, that for pandemics, what we decided was in rotations, that we would be doing virtual rotations, which are like grand rounds, in which we try to air the hospital facility or vicinity, and students participate in patient consultancy discussions and rounds remotely. We have been practicing redeployment, where we assist students to have non-clinical roles, like data analysis, like support, like contact tracing, where they can come and they can be in safer environments and they can work with us. We shortlisted our cases, particularly in the critical care and public health regions, for students to just go to relevant wards and relevant rotations and have maximum safety. And obviously, at all portions, you have to have enough personal protective equipment for students who are coming from high-risk areas, who are going into the ICU or medical wards where there's a risk of pandemic outbreak again, or there's a risk of people who are coming from other regions and they might have some sort of disease or transmit infectious diseases. So all of these things have to be there. Similarly, we have policies for earthquakes, that we have an emergency response training prepared, that students have first aid and basic triage. They know evacuation techniques in the university. They are given simulation for real life scenarios, so that they can easily evacuate someone if they're in a region where this happens. Because recently also we have had 2 earthquakes. Pakistan is in the tectonic belt. They have not been of bigger magnitude, thank God, but still preparation is imperative, even parts of your curriculum. We've identified backup clinical sites, which are earthquake resistant, in case we move into a red zone for clinical rotations, like I mentioned before. So if it's for a longer period of time, we try to make sure that our students get some sort of exposure over there and they are relocated. And then we regularly give sessions to our students. They should, and everywhere, they should know about the communication plans, about the National Earthquake Center, about the activities of the government, or who to call in the institution, who to call in case there's any sort of issue going on, or evacuation routes that they need to know about. Similarly, we have a plan for floods, which includes climate change and safety training, flexible scheduling. Community outreach is something we believe in very strongly. So these are the students who were contributing to the flood donated areas in Pakistan. And what we did was that we identified students. We do that on a regular basis, that we identify those students which are from flood prone areas or from earthquake prone areas. We keep checking on them as part of the wellness policies. And we try to make them the community or team leaders when we go for rehabilitation efforts, because they understand the terrain, they understand the language. So it is easier for us to navigate with them. And this builds a sense of responsibility and community in the students. It gives them a chance to give back. It gives them a chance to create. But obviously, this is always done after an assessment of their safety. So if we are equipped and we think that they can safely go and safely come back with minimal hazards, this is known as the Alpha Tough Society, and they go ahead with that. At all levels, you have to have policies. So these are our policies for contingency training. We have a well-being and resilience policy separately for students and faculty in case of any disasters, because it's not just about the educational portion. It's a lot about the psychological as well as the well-being of the student or the faculty member. So we have counselors in place who work through telehealth. They also work face-to-face, and they also work online depending on the conditions. We have alternate online policies for assessment, which is very important. I'll be discussing that shortly. And then we have, we use near-peer mentoring in medical college. So we have a policy for that also. If we shift to online, or if we shift to emergency situations, that how are the mentors going to be accessing the students? How will they go ahead? What will be the resources? How will we be able to share? And finally, we have a co-creation policy where students facilitate the faculty in making modules and making different sorts of plans during times of disruption. So briefly on the faculty wellness policy, it includes awareness and training of these circumstances at hand. You have confidential counseling services, peer support networks. We've been having flexible work arrangements throughout the pandemic. Faculty members who were affected by the floods were also asked to work from home if it was possible, if there was no way they could relocate, because the floods have literally damaged acres of land and there's no area of land in certain areas. So they were given leaves accordingly, which were paid. Stress reduction initiatives are held on the campus most of the time. They're also held online in case we are not allowed to be on the campus because of any situation. Regular check-ins are done with faculty members who are currently from flood-affected areas, but also when it was time of the earthquake. And we have a communications channel which is always open with them. So communication is key during all of emergency planning. Similarly, we have student wellness policies, which are more or less the same, except that additional support is given obviously to the students with the help of faculty training, with faculty development, faculty where people are accessible to them in case academic loss is being done. So their attendances are well documented. Replacement assignments are given if they are not able to come to the university for a longer period of time. We have reporting mechanisms for those students who are in flood-driven areas about the condition in the region and how the university may help as a welfare society also. So one of the key things is assessment. I've mentioned this before, but assessment was very tricky for us during the COVID times. So at that time, we were able to really think about how we were going to do assessment. We majorly came up with asynchronous methods because a lot of our students were having trouble with bandwidth when we went online for synchronous assessments. So asynchronous, low bandwidth friendly methods like submission of answers after a particular time, submission of assignments, submission of open book questions. We have trained the faculty, obviously, for going through these measures, for going through these strategies, because in Pakistan, we don't do open book questions in medical colleges. So this was a first for us. Then adaptive assessment policies like e-portfolios, we used them. We also used them during the flooding because a lot of our students could not come for regular tests. Similarly, alternate assessment locations in case the area is under threat or in case it's flooded. So we've discussed with the government about where we can go. We have other medical colleges, particularly government-based, where we have tests. And they are prepared also in times of COVID to become centers. Submission formats are very important. Struggle at times. There are also issues with cheating and with other policy matters online. So it's very difficult to have MCQs and short answer questions with students. So you have to have assignment-based or portfolio-based assessment platforms. Practicals, we decided to have shorter groups who would come and perform practicals face-to-face. Those students who had the disease, obviously, for them, we had online simulation practices and we had assessment through whatever medium they could actually answer questions. For example, we had been using WhatsApp. We had also been using Moodle. We had been using Zoom for students who could not come in excess. And students who were basic or who could not under any circumstance were obviously, according to policy, they were given time later. And then some of them were requested to sit for the supplementary examination. Some of them were given leeway in their attendances. So all that comes under consideration for equity rights also. Because particularly during the flooding, there are areas in Pakistan which had no water at all. They were fine. There was no flooding. So we had students from there who were coming and going and everything was good with them. There were areas where there was nothing. They did not have food for weeks. They did not have basic supplies for weeks. So we had to develop a policy for how to deal with them, to give them more time in the year, to utilize the vacation or prep time for finals to make up with them, and to give them some sort of relaxation in the examination system also. So these were some of the major things we did as policy design, and I'm sure that everybody adopts according to their own plans. Coming to online and e-learning policies, thanks to the online shifts and the major work in this field, we now have developed online policies with Higher Education Commission of Pakistan. It gives us clear guidelines how we have to proceed with online distance learning in case of pandemics, in case of normal studies. The Pakistan Medical and Dental Council is responsible for our medical education, so it works with that. And similarly, I'm sure that the council in Turkey also has been active in this regard. I've read some papers. So online and e-learning policies need to be adhered according to your national recommendations. But you have to understand that you may have to minimize things according to the situation. And for that, what is recommended is that you write to your policymakers or to your authorities and gain the proper get-go or the proper legal permission to move on. So that was all about the different strategies that we can adopt and that we have done. I'm very glad that all of you took the time to listen to me. These are some of the references. I am available at this email address if anybody, particularly the students, wish to communicate. It's always a pleasure to hear from our neighboring countries, our brotherly relation countries. And I'm open for questions if anybody has any. Thank you so much.
Thank you so much, Professor Atta, for such a wonderful presentation. I think that you have done a great job because implementing all of these policies is not an easy one. You know, even sometimes there are challenges, especially people resist to changes, in fact. So what you talked about, all of these learning, especially policies, and in such a disaster, is not easy one to do them. So I think that you have done a great job in this manner. And
thank you so much.
Yes, but it's not easy because before just a couple of months here in Turkey, we had some, you know, disasters that it was not so easy one also for us, because the students already from the face-to-face courses, they go to the online one, which was not so preferred one, of course. but we have to do that, unfortunately. But of course, combining face-to-face or online courses or blended learning one, such in the first speaker already, Professor KUPESIC talked about some challenges in this manner. So it's not an easy one. So I think that you have done a great job in this manner. So thank you again for sharing with us this knowledge and the information, policies, everything. So I would like to take the questions, and there is one question here from the students that are on the chat, but I have two questions, and some are already sending on the phone that are on the class students now watching you there. The one is here. Thank you for your presentation. I want to ask, what are the key competences and skills that healthcare professionals need to effectively respond to pandemic and disaster, and how can these be integrated into medical education programs? In the chat box, you have question, maybe you can check also there.
Okay, thank you very much. Thank you. That's a very important question. So, first of all, like I said, that you have to prepare in advance according to your context in your region regarding the disaster or the pandemic. Pandemics, obviously, they are usually worldwide. So WHO does have guidelines for that. But disasters, according to your geography, you should be knowing that what can happen. And according to that, the major competencies, like I mentioned in the slide, are infection control. That is a priority, and that should be included in the curriculum. Patient safety, disaster management, crisis communication, rehabilitation. So what can easily be done in most curricula is if you create a special set of workshops or a specific module related to pandemic preparedness or disaster preparedness, which will be especially focusing on all of these things. Otherwise, you can have them in parts of your curriculum. Ideally, we should be practicing that throughout, but in Pakistan, we don't have disaster management and crisis communication as part of the core curriculum. So we do that separately as part of our module for disaster preparedness. We have a series of workshops that go on with the regular curriculum. And according to the level of the student, we teach them how to be prepared for disasters, which includes counseling, which includes first response, which includes basic life-saving BLS training, acute trauma training, first aid responses in cases of floods, and in cases of earthquakes, in cases of pandemics, how to secure yourself and how to secure the patient. So those are basically some of the things that we are working on, and we plan it in separate workshops or as a separate module.
Thank you, Professor. Another one is related with, in fact, collaborations. What role does international collaboration and knowledge sharing play in enhancing pandemic and disaster preparedness education in medical schools and institutions? In fact, you mentioned a little bit, but about international collaboration, would you like to add something more?
I think that's a very important question. I already discussed about that you have witnessed in the COVID-19 pandemic that there was a lot of international collaboration. We were getting the guidelines from the NIH, from the US. We were looking to other countries for vaccinations, for protocols. So in the pandemic, obviously, it becomes one world and one health. So there's a lot of collaboration, and that should always be going on even during times of safety. I strongly believe that I read a paper from Turkey where they had looked up to issues that had happened in Japan because of the earthquakes that had happened there previously. So there should be more collaboration between our regions, which face similar disasters, natural disasters, and we should be learning from each other about how we are rehabilitating, how we can take the students forward. So I think that has a major role, yes.
Thank you, Professor. There are questions, but of course, due to the time, I say to the students that you've shared already your email address. If they would like to ask something, they can send a message to you. So thank you again for being with us here, for sharing your knowledge. And let's see you next time here in our university campus face-to-face, all of our speakers that are already here today.
Thank you so much. I look forward to coming to Turkey, and particularly to Istanbul. It's a beautiful place, and I hope to be visiting soon. Thank you so much.
Thank you, Professor Atta. Yes. Now, we are going to continue with another speaker, Professor Radu. And before starting, I would like to share a little bit information and introduction about the professor, and then I will give the speech to the next speaker. Our next speaker will be Professor Dan POENARU, and Professor has a bachelor, master, and PhD, especially on the physical education and sport, with a double major in skiing and fencing, where he graduated in 1992 from the National Academy of the Romania, and continue in the area of physical therapy and human kinetics. Of course, if I miss something, I would like from the professor to add here. He has worked for a long time as at the National Academy of Romania at the Physical Education and Sport Department for over 5 years, and as a physiotherapist for the professional athletes in Canada, United States, and Australia for over 20 years. And he is working as a professor at the School of Physical Education, Sport, and Kinesiotherapy since 2020 at the Romanian-American University, which is one of our partners that we collaborate together. The research expertise of the professor is physical education and sports, kinesiology, and athletics. And we would like to thank again for being here, Professor, with us. Welcome to our symposium. The speech is yours, Professor. I'm now stopping my sharing so you can share your presentation. Welcome again, Professor.
Thank you. Thank you very much for your warm introduction.
You're welcome, Professor.
I would like to ask you if my screen is visible.
Yes, just can you please click the F5 to make it a full screen? Yes, it's okay.
I think it is now, right?
Yes, it's okay.
Thank you very much. Thank you again.
Welcome.
First and foremost, I would like to express my gratitude to our host, Aydin University from Istanbul, Turkey, for organizing this symposium. I would also like to say a warm thank you to all the staff people that worked hard to make such an event possible. I think we all know what you are going through during the preparation stages and the amount of stress you are exposed to. So thank you. Last but not least, Professor Atta and your dean, thank you for inviting me at the conference. I assure you it is a great honor and it means a lot to me. Yes, I'm excited to be here. Probably you can tell. I like this topic, and the big challenge is trying to decide what to cover in the next 30 minutes or so, because there is so much great information on the subject. Now, just to put things in a context, I would like to introduce you to a few facts. However, it is data that you might be aware of, so I will try to be brief. We estimate that for most of human history, the global population was a tiny fraction of what it is today. However, over the last 2 centuries, the human population has gone through an extraordinary change. If in the 1800s, there were 1 billion people in the world, I think 1852 was the year when we hit the 1 billion landmark. We were 3 billion people in the world when I was born, almost 60 years ago. And we are more than 8 billion people today. So global life expectancy soared from 34 years in 1913 to 72 years in 2022. This is, of course, a combined effect of many factors, but mostly it has to do with advances in science and medical sector. Things such as vaccination, antibiotics, and sanitation, to name only a few. Long term, we do not expect this trajectory to change at all, which is great. But of course, this trend, it's bringing us some challenges as well, especially when we are discussing resources which are getting scarce. However, as challenging as it might be, the population growth, it's only one dimension of the issue. What is even more important for our discussion today is that you see the population age structure has changed radically over the past 50 years as well. Between 1970 and 2020, fertility dropped in every country in the world. When United Nations and World Health Organization were established, there were 7 times more children under the age of 15 than people over 65 and older. By 2050, these groups will be exactly the same size. We estimate that. Between 2000 and 2050, the global share of people of 80 years old and older grew almost 5%. In Europe, some countries such as Turkey or Poland might have a better demographics than, say, Italy, Greece, or Romania, but the point remains, it is in an integrated world like the one we are living in, we are all going to be affected by this phenomenon. So you can see on the screen, I hope, it represents a graph for the change in demographic between 1950 and 2050, with the percentage of young children under the age of 5 crossing and becoming lower as a percentage than people 65 and older. And that just happened just before 2020, so probably around 2018, 2019. Just data. But the problem is, do we really have a problem? And if we do have one, how we are going to solve it? I mean, there are papers out there describing this demographic shift as the white tsunami. Very dramatic, I would say. So it is a case for concern, or we are just overreacting. Obviously, it is a very complex phenomenon, which with many ramifications, social, economics, and I think we should take it seriously, and I will explain to you why. It might affect our economy. I mean, in the way we are producing goods and consuming them. It might challenge even the social bedrock of our society. We can assume that different cultures will be impacted differently by this, but one thing it's almost certain that in this century, everybody will be touched by it. But what I really try to address today is the healthcare cost, which we estimate it's going to rise at the very moment when I'm not sure that we can afford it. And the second one is the strain on the medical sector, where we need professionals such as doctors, nurses, technicians, when we don't really have them. So how do we address this issue? I think it all starts with the idea that we are aging. It's our destiny. We become weak, frail, losing our cognitive abilities, and therefore there is nothing we can do about it. It's really our destiny. I will argue that, well, it is more we can do than you might think of. I choose this picture on purpose because you see an old car, it becomes rusty because it's only metal and glass and plastic. But we, as living things, we have more say to this than an old car. So I would like to tell you a story. You see, in the early 1800s, when the speed on the railway was just over 30 miles per hour. Dr. Dionysius Lardner stated, which I quote, "Rail travel at high speed, it's not possible because passengers unable to breathe will die of asphyxia." And about the same time, 1842, a very well-known French philosopher stated, which I quote, "We can never learn," talking about stars, the internal constitution, or in regard to some of them, no heat is absorbed by their atmosphere. We can never know anything of their chemical or mineralogical structure, and much less that of organized beings living on their surface. And my favorite of all is Lord Kevin's remark, heavier than air flying machines are impossible. Well, as you can imagine, I have no intention of mocking these people's opinion and statements. I just try to make a point, which is what might seem impossible today, it might turn out to be the norm in the future. And I have two remarks for especially for the younger members of the audience. Number one is sometimes you have to have the courage to challenge the impossible in order to make it possible. And the second one is everything, it's a collective effort. I mean, the fast train or the jet airplane didn't happen overnight. It's a slow, gradual process. And a lot of people participating in this. One other thing is, we people as a species are smart, we are clever, and we are not taking no for an answer. Well, at least not when it's coming to technology. But how about when it's coming to our biology? So what I'm going to talk now about is, well, when we are thinking about aging, we are talking about two dimensions. One is the quality of life, and one is the quantity of life. So a longer life might not mean a healthier, productive. So it doesn't include the quality of life. But what if I propose to you something which is simply cheap and convenient? It might increase your life expectancy. It has the potential to keep you active and independent for as long as possible. It can reduce the healthcare cost, which I was talking about. And very important, it can reduce the human suffering. It's called physical exercise. If you are considering the main leading causes of death for people over the age of 65, you see heart disease, cancer, Alzheimer, and so and on and on. If we are considering people between the age of 65 to 85, not much changes. It's just the cancer, it's a little bit higher in that age group. But I choose simplicity, so that's why I present only this graph for people over 85 years old. So the point is, I will try to argue that physical exercise have a big influence in all these areas. So if you are looking at the 26.8 other causes of death for people over 85, a big percentage of that is actually about falls. Older people are falling, and many times this is leading to serious injury, even death, because a fracture at 85 years old, it might never heal. So if we are looking at data over 14 million, which is 1 in 4 adults, report falling every year. 37% of those who fall report injuries that require medical treatment. Each year, about 50 billion are spent in the US on medical costs related to older adults. If you think about the United States, yes, of course, it's a rich country. But even for the United States, 50 billion, it's a lot of money. Of course, physical education and being physically active can reduce substantial these numbers. If we are looking at the graph, aging means a reduction in endurance, strength, and function, which leads to a decrease in physical activity. Of course, genetics has a big say in it, but we like to say that somehow, genetics is loading your gun, is your action, your decisions, that it's pulling the trigger. So in other words, for a person with say, bad genes, a history of heart disease or cancer or stuff like that in family, can reduce actually the risk by choosing a healthy life instead. Of course, with all this, it's coming increase in hypertension, insulin resistance, cardiovascular disease, decrease in cognitive function, increase in type 2 diabetes, and so on and so on. But you can look at this from a positive point of view, which is if you look at the screen, physical activity is right in the middle of the screen. Just by increasing the amount of physical activity, actually you can reverse all these biomarkers. This is, well, a lot of areas where which are impacted positively by physical activity. Of course, we don't have the time to talk about every single one of them. We are going to talk about a little bit about the brain and the cellular aging and what's happening at the level of the body. Because you see, I would like to argue that aging can be a very different story. It can be a healthy, successful, productive one, or it can be very hard, ending up in a wheelchair or in a healthcare facility. Years ago, I had the opportunity to work with a lady which she was 85 years old at that time, and actually the medical doctor sent it to me because after a fall, she was afraid to walk by herself, and she asked for help at for the doctor, and the doctor said, "Well, I'm sorry about that. I can't really do it because that means to have you in a wheelchair in 6 months, and then probably you are going to die in about a year. So what I suggest to you is exactly the opposite, being more physically active." So yes, I had the opportunity years ago to work with this lady, and I have good memories, quite a successful story. So yeah, you might be surprised. Anyway, what I like to touch now is a little bit of common sense stuff. And then we are going to talk about some science, which I hope you will find it interesting. And very fast, I will try to make a few recommendations about minimum and maximum of physical activity as we age, with recommendation for training for performance or training for longevity, which is not quite the same thing. So to start with the common sense stuff, physically activity improves and maintain physical and cognitive function. This is easy. It's a no-brainer, but it's coming handy as we go forward. You see, when it's coming to physical activity, the golden standard is this VO2 max, which is equivalent with power and energy, and if you includes many areas, so ventilation, diffusion, saturation, cardiac output, blood flow, oxygen extraction, and oxygen use. So if you want to increase your VO2 max, you have to address all this area. So to be short, people with a high VO2 max are able to work longer and harder than other people. But how did this translate in well-being in an older age? So you see the graph, which represents the endurance-trained people, active people, and then the sedentary people. So I will just say that the lines represent the mean, the medium data, because as you can imagine, there is a lot of variability. So some people are individual above the line or below the line. So as you can see is I will address the black line, which represents active people, not the endurance trained ones. Just make it simple, right? So if you look at the line and consider that variability I was talking about, some people at the age of 50 or 60 might be well above the level of people in the 30 or 40, which are sedentary. But you can see the lines are dropping. And consider somewhere a point, somewhere around 20-25 units of VO2 max, where the people coming below that line are going to actually be considered disabled, so they can't move by themselves. And this is very important because you can see the line drops, people are aging, but staying active. You manage to be above that disability line longer, if any, going down below the line. And it's not just the work capacity, is we have studies that are showing us a strong connection between exercise capacity and the whole cause mortality. This is a study from Stanford University, which took over 6,000 men with over 3,679 with cardiovascular problems. Average age was 60, and after 7 years follow up, they figure out they had 4.5 more deaths in the group with which had a lower VO2 max. And this relationship held even when adjusted for other comorbidities and difference in age and things like that. And this is not only for the cardiovascular fitness. It's always it's valid when it's considering muscle mass and strength. So you can observe a decrease in abilities as we age. But there is good news and bad news, because at any point in life, if you decide to become physically active, if you are not already, you can increase your abilities, which as you can see, it puts you or people that are active above that disability threshold. And talking about this, I would like to present this study. It is not a new one, actually 1990, but is the oldest group I could find. So that's why I chose this study to present to you. So the age between 87 and 97 years old, frail elderly men and women in a long-term care facility. They've been through an 8-week high-intensity resistance training. Now, high-intensity training, please consider and put it in a context. We are talking about people, around 90 years old. But anyway, quadriceps muscle strength increased by 174%. Mid-thigh muscle area increased by 9%. Increased in gait, especially hair climbing power and balance. So this balance, you see, please make the connection with what I was talking before, presenting that data about older people falling and being actually a leading cause of death for people over 90 years old. But more important, I think, is this increase in spontaneous activity level correlates with cardiovascular fitness. So bottom line is never too old to benefit from exercise. Nothing so far is more effective at reversing muscle loss and resistance training. I know when it's coming to strength training, and people tend to shy away from this because, well, it's kind of complicated, sets and reps, and they think might need a gym facility and something like that. But it's not always the case. I mean, even with elastic bands or body weight, you can still achieve a lot. I got two references. One is from McLeod 2019 about the resistance training as the prime contrameasure for related chronic disease. And my favorite one is the 10 biomarkers of aging that you can control. It is quite an old theory now, probably almost, I would say, 25, 30 years old, but it's one of my favorite because it was the first time when I realized that weight training, it's much more than function and aesthetics, as younger people are regarding it. It's life itself. So basically what I'm trying to say is these biomarkers of aging as cardiovascular, high blood tension, cholesterol, and things like that. It all been tracked to a decrease in muscle mass. So the theory states that by increasing the muscle mass, we are restoring this biomarker. So we don't really have the time, but I think it's really interesting, and I recommend it to you. Now, when it's coming to this science I was talking about, how does it really works? I mean, how the systems are talking to each other, and I try to present faster because I know I'm a little bit running out of time. But if you are thinking about this, what we call healthy or successful aging, we have these internal factors and external factors. As internal factors, I consider diet, sometimes includes medication, environment, relations, and of course the interactions with the outside world, which is a physical activity. And when it's coming to internal factors, we are considering, genetics, physiology, and psychology. And you see all this, it's connected. I can tell you that we are working on a app because we are trying to put numbers of this. And considering this network, for example, somebody who is having a bad diet can compensate and still be relatively healthy and staying above that disability threshold I was talking about by increasing the level of physical activity, and vice versa. So somebody who has problems in genetics, for example, like a history, like a family history of cancer and cardiovascular disease, can compensate this potentially bad genetics through external factors such as physical activity. Anyway, this is a work on progress, and hopefully next time we can discuss more about this, because like I said, we just try to put this in quantify and put numbers on these relations. What I would like to talk to you is about this crosstalk between systems. And I will argue that in this case, muscles are working as a pharmacy. If you are asking yourself how this is possible, well, we have this called myokines, which the first one was discovered about 20 years ago. And now we know about the existence of about 650 to 3,000. Depends who you are talking with and what things you like to include. However, it's probably around 5% that we really understand. But the most important for our discussion are these exerkines, which are released during the exercise. So this is the connection between the muscle and basically any other system in your body. So when exercising, the muscle is releasing these exerkines, which are basically affecting the whole body, the whole organs and skin and so on and so on. The point is, how this works is it targets inflammation, right? So what we know is that acute inflammation, it's good, right? Like you sprain your ankle, your acute inflammation, it happens because the body tries to protect you and heal the area which was affected. Systemic inflammation is bad. It's associated with cardiovascular disease, type 2 diabetes, cancer, dementia, and so on and so on. Also, obesity, sedentary behavior, poor diet increase the systemic inflammation, but physical activity increases the acute inflammation, but decreases the chronic inflammation through this exerkines which are releasing during the exercise. So trying to explain this to you, a sedentary behavior, it's you can see probably in the left corner of the screen, being sedentary, working at the office, doing your homework. In the background, you have now a high systemic inflammation, higher myokines, and then the next frame is becoming physically active. The background now during the exhaustion phase, we release these myokines, acute inflammation decrease, micro damage and oxidative stress, and the third picture, which is the homeostasis phases, this circling myokines fall because the need to repair the damage that's been done through the exercise. So to be short, how this works is, imagine you are calling a handyman to do some work at your house, for example, I don't know, fixing a hole in the wall, and when he's fixing that hole in the wall, is saying, well, you have a problem, your structure, it's been affected by water or whatever. If I'm here, it's gonna cost you a little bit more, but I can fix this one for you. Pretty much the same mechanism. It happens in our body. A little bit more energy to spend for these repairs, but if these myokines are circulating, it's great. They can fix at the cellular level damage done by not only by exercise, but for example, let's say for unhealthy lifestyle. What I would like to address is the stuff that's happening in our brains when these myokines are start circulating. The brain releases growth factors, which are increasing the production of new blood vessels and what we call neurogenesis, so the new brain cells. So sometimes people think, the brain is just what it is when we are young, and then we are aging, and damage, it is inevitable, and that's it. No, the point is, it's still a lot we can do, because as you can see, through physical activity, we can increase the production of new brain cells and this plasticity of the brain. We know, I'm trying to go, sorry about that, I'm trying to go a little bit faster now. I realize I'm kind of running out of time. What I would like to touch is the connection with the memory. This hypothalamus, which is it reaches its peak when we are about 25, 30 years old. And we know it shrinks about 1% every year. And this development has been thought to be inevitable until this study from UCLA came about 3 or 4 years ago. Basically, they were comparing cardiovascular exercise with stretching and yoga, and something really interesting. They discovered that people that they were walking briskly for 1 year, 3 times a week, actually they increase the size of the brain by 2%. So instead of getting 1 year older like everybody else, they got actually 2 years younger. Really, really interesting. Well, I'm not going to pretend that just by exercising you are going to stay young forever. I'm not going to be not going that far. We can observe this by looking at the declining performance in athletes. It doesn't matter we are talking about 100 meters or 10,000 meters. It's pretty much something happening around the age of 70. It's a steep decline in the ability. We don't really know yet if something happens at the cellular level or is just the effect of some other mechanism. Maybe people are not pushing themselves as hard. Maybe the injuries are taking longer and stuff like that. Now, when it's coming to recommendations, just to put the things in a context, we can take the physical activity guidelines, which is for cardiovascular between 150 and 300 minutes exercise a week of moderate intensity exercise, which is I think a lot. Okay, if you are having the time and the will to put this 150 to 300 minutes of moderate intensity exercise, it's great. But what I would like to show you is, if you're looking at the graph, is the drop between 1, which is the hazard ratio of mortality. You see the big drop happens right before that recommendation of 150 to 300 minutes. So what I try to say is, even if you are not fully meeting those 150 to 300 minutes, you can still have a huge benefit by just doing a little bit. And please don't take me wrong, I'm not saying that you should not consider those recommendations, 150 to 300 minutes. Definitely you should. I'm just saying as a help for people that they think might not have the time or the energy, or it's too hard or whatever, right? Just by a little bit, you can still decrease substantially your risk of cause mortality. And what you observe over that meeting those recommendation of 300 minutes, it's no evidence of increased risk after that. So the line kind of starts plateauing. This is a graph that shows, of course, people getting older and older, less and less physical activity. Somewhere say around 25-30% of the people are actually meeting those recommendations, right? But think about those 50% that are not meeting the recommendations, not at all. So what I'm trying to say is those people will benefit even by a little bit. Don't even need 150 minutes, right? They are not doing anything right now. So just by doing a little bit, just by doing something, and that might be, just taking a flight of stairs, park your car a little bit farther away from the store, walk for a stop, and then take the bus. Doesn't need to be necessarily a workout in a whatever gym or a gold gym or some facility like that. Anyways, I apologize for I know that the time is short, and my mistake.
No, Professor, you're welcome. Everything is clear. Thank you very much. Also for Tariq for waiting. It's not, you are welcome. You can continue.
Oh, thank you. What I would like to say is we have proof and to believe that this high intensity training it's very, very beneficial for two reasons. One, it does not address directly the cardiovascular aerobic system, but it still has a lot of benefit. It saves time, and it's becoming more and more popular these days, even with older adults. Now, about sitting, this is a risk factor in itself. And what I was ready to discuss and argue is, even for people that are actually meeting the recommendation of 150 to 300 minutes a week, please don't feel you are safe because after you meet those recommendations, then you can sit 9-10 hours. This is been proved that it's an independent risk factor, as I said, and our recommendation is to stand up and walk briefly every hour or so, even if you are meeting those recommendations. Otherwise, you are probably going to lose much part of the benefit, the stuff you work hard for. And yes, we treat this in media as sitting kills, and sitting is the new smoking and stuff like that. Well, yes and no. Please consider that not all sitting it's the same. As you can see, we sit at the desk versus people that are living in hunter-gathering communities are using to sit. It's more active than sitting at the desk. Okay, what about too much physical activity? Unfortunately, we don't have a lot of data about this because, as you can imagine, not a lot of people, especially when we are talking about older adults, are falling in this category. But definitely it is like a G-shaped curve when the benefit it starts being lost and pushing that limit. Even it might become a risk factor. Now, recommendation for performance. Of course, there are some advantages and disadvantages. It's a personal choice. The only thing I will say is, even for performance, we are recommending this 80 to 20% training, which 80% is low intensity and only 20% is it's high intensity. Especially for older people, when injuries are taking longer to heal and it's needed more recovery time. As a recommendation for longevity, of course, advantages and disadvantages, like you can expect. Probably one of the most interesting studies is one study. It came actually last year from Copenhagen, in Denmark, which states that you will be surprised by this. The payoff in increase of lifespan, it's smaller for activities such as gym work and cycling and even swimming, and it's more benefit in running outside, gardening, dancing. So it seems to me that it's some connection with being outdoors and being in a company of other people. So in summary, what I would like to say is try to be physically active, because the body it's watching you through those myokines I was telling you about. And well, remember that a convenient life, it's not necessarily a healthy life. I mean, we work so hard in the past 20 years, 50 years or so, to engineer the physical activity out of our lives, which is now we start realizing is probably not the best thing to do. And to conclude this presentation, I would like to say that please, at the personal level, consider that take the invitation to stay physically active through your life, so you can live a long, healthy, and productive life. But also, the challenge is, as a professional, as a specialist, try to communicate with your patients, with your community, even with people that are in charge of writing this health policy in your country or community. Make them aware that it's not about spending funds, it's about saving money, because people are living a healthier and more productive life. And I think it's all worth it in the end. The last remark I will make that is, you know, in the past, physical education, it was meant for young children in school, but maybe in the future we will should consider include the senior citizen as well in this process. Thank you very much for your time, and I'm sorry I was a little bit long with my presentation. So thank you very much, and if you like to ask anything, I'm here.
Thank you very much for such a presentation, Professor. It's a very important topic because everybody is looking for how we can live longer, a healthy life. So you talked especially, your focus was in this manner, your presentation. So thank you again for such a beneficial presentation for all of us, for the staff, for the students. And I just would like to take some questions from the students, if there is here. There is one question here. Maybe you can look at the chat box, Professor. You can check already the question there. Is HIIT safe for middle-aged people with sedentary lifestyles?
Sorry?
HIIT safe for middle-aged people with sedentary lifestyle?
Yes.
So this is the question.
Well, everybody will benefit of a healthy lifestyle, and I was trying to make the point is we don't need to be scared of you know, spending money and time, and you know, use a gym or something like that. It can be at least in the beginning done anywhere, even at home, even in a park. For mid-aged people is I try to remember that this study which states that for people meeting those recommendations, 150 minutes to 300 minutes, we are looking at in say 25-30 years. We are looking at probably around 6 months of being physically active, and this 6 months might increase our life expectancy up to 10 to 12 years. So I think it's time well spent. And this is talking only about, like I said, one dimension. It's just the living a longer life, but which I think it's even more important is the quality of life, because of course I would like to live to be 85, but I would love to be an active, healthy, independent 85 years old. So I hope this answers.
Thank you, Professor. There are a lot of questions from students that coming from the class, but just one more question I will ask. What is the role of community-based interventions such as group exercise groups, programs, and senior wellness centers in promoting physical activity and social engagement among older adults?
Oh, this is great. I love it. Yes, it's very, very important, because you see, maybe this is actually a very powerful tool, because we try to convince people, especially older people, right, senior citizens, to be physically active, which I know it's a challenge. Trust me, I've been doing this for over 30 years. I think we should try to attract them, not by telling them how important it is to be physically active, which it is. I think we should try to convince them and this is probably much easier, to be part of a community. People like to, they want to belong. And this is my experience also, trying to build a small community inside those, can be a gym, can be other place, right, where people are coming to interact with each other and you know, discuss different issues, and in the process they are physically active. So you see, I hope you understand what I mean. It's not putting the, you know, the physical activity in front, because this is they might think, you know, it's hard, it's not for me, I'm old, what's the point, blah blah blah. But I try kind of to put the social aspect, the community aspect in front, right? And now they might be willing to be physically active. You see what I'm saying is sometimes not even realizing fully that are physically active because they have to be physical active. No, they are physically active because they are members in the community, right? So yeah, then it can be any type of activity. Yeah, as long as they feel part of something, you know, volunteering, very important, working with maybe volunteering, working around a kindergarten or a school. It's just great for them.
Thank you very much, Professor.
Thank you.
Yes, thank you. Of course, there are questions, but due to the time that we already for the next speaker, we have to complete now for this presentation. We would like to thank a lot again for such a beneficial presentation, which is related especially with the healthy aging for the people, even in which age they are. And we again wish you to see you in our campus in next time face-to-face, all of our speakers that are here and sharing their knowledge with us. So thank you again for being here.
I would love to.
Now,
thank you very much.
We will continue with our next speaker. Thank you again, Professor.
Thank you.
Yes. Now our next speaker is Professor Dr. Saba Tariq. And I would like to thank a lot, Professor, also for her patience that was waiting here. And before starting the Professor, again, I'm going to give a brief information of our next speaker. And our next speaker, Saba Tariq, who graduated from the bachelor degree in the Medicine and Surgery Department in 2009 from the University of Health Sciences, Pakistan. After that, Professor did already the Master and the PhD degree in the Pharmacology and Therapeutics in the Sheikh Zayed Postgraduate Medical Institute and the PhD in the University of Health Sciences in Pakistan. The professor currently already continue where she is now in the UK, as I know, is a postdoc fellow at the University of Birmingham in England in the Pharmacology and Therapeutic Department. The academic career of Professor started as an associate lecturer. Of course, it is the end of that one, but she started as an assistant professor in the Department of Pharmacology and the Therapeutics in the University Medical and Dental College, Faisalabad, Pakistan, between 1921. And then as an associate professor at the Department of Pharmacology and Therapeutics, again at the same university. And since 2021, she is working as a professor at the University of Faisalabad in the Pakistan since 2021. And again, as an associate lecturer in the blind learning field, Arden University, England, since 2023. Of course, if I miss something, I would like from the professor to add here. And the professor, besides her academic duty, the professor has a head position department since 2021 at the University of Faisalabad in the Pakistan in the Pharmacology and Therapeutics Department. Professor's research expertise is in the medical and health sciences, especially pharmacology and therapeutics, in endocrinology, rheumatology, osteoporosis, and medical education. And Professor, even she is a young scientist, she has over 649 citations and has a lot of awards in this respect. So I would like to thank so much for being here with us. and she's going to share our knowledge and her knowledge with us. Thank you for being here, and welcome to our symposium, Professor Tariq.
Thank you so much, Atta. This is a wonderful introduction for me, and I'm highly honored and obliged, and I present my heartfelt gratitude for the organizer of the conference to invite me as a guest speaker, and I'm very excited to present in front of you. So let's share my screen. Am I audible to you?
Yes, you are a co-host. You can share your presentation. And welcome again, Professor.
So can you see my presentation?
Yes. Could you please do it a full screen? Maybe you can make it bigger, like in the middle on the square, on the top, on the right. On the right side, where there is a square, I think, next to the X.
Is it okay with you?
Yes, it's better now. And the full screen, yes.
So today the topic that I have selected for this conference is artificial intelligence in academia and medical writing. And as Atta has already introduced me, so I'll not waste my further time in my introduction. So let's move with the topic. So artificial intelligence is, as a whole, consists of 2 and 3 things. It consists of data science, deep learning, and machine learning. And all of these things combine to form artificial intelligence. Machine learning is basically a subset of artificial intelligence which is built on model based on training data to make predictions. And artificial intelligence means to create something as a machine to mimic as a human behavior. There are certain benefits of the artificial intelligence, which includes it enhances the learning experience, it improves the teaching efficiency, it provides feedback on written work, it provides innovative ideas for the researchers, it is easily accessible, and we can have summarized information and resources through artificial intelligence. There are certain concerns with artificial intelligence as well. The availability and cost is one of the concerns because all of the artificial intelligence tools are not freely available. So some of them are expensive. Then there are certain ethical issues surrounding its education. Some of the technology is still immature and lacks standards and regulations, which needs to be updated. And obviously there is dependence on technology as well. So we will go through one by one through different tools which are available in artificial intelligence and which we can use in academia and medical writing. So the first tool is ChatGPT. So ChatGPT is a generative AI chatbot that interacts with you conversationally, a human word. It is basically developed by OpenAI, and it is at the forefront of natural languages processing. So it engages in conversation and generates text that closely resembles human communication. So I'm sure all of you must have heard about ChatGPT, and it's very easy to work with ChatGPT because you just have to put a question into ChatGPT and ChatGPT will answer. It is a free premium tool, means it has a free version and a premium plan. And I have given link to all of the AI tools that I'll present in my presentation, and you can check it out yourself about the different tools that are available for academia and medical writing. So this is the demo of ChatGPT. What ChatGPT do, you just have to write an input in ChatGPT. For example, in this case, I have write, can you make learning outcomes of drugs used in acute pulmonary edema? And what ChatGPT is doing, ChatGPT is making learning outcomes for me of different drugs which are used in heart failure, acute pulmonary edema. For example, it is giving the learning outcomes of dobutamine, which is a positive inotropic agent. It is giving learning outcomes of ACE inhibitors, which are used in acute pulmonary edema. So in this way, you can ask ChatGPT any question and ChatGPT will reply accordingly. The next software that we can use in academia and medical writing is Perplexity. Perplexity is another generative AI chatbot that lets user ask questions and get response conversationally. So you can just go to Perplexity and ask it a question or request something, and you will see the concise version at first, but when you can click on that version, you will see the detailed version of your response. So I'll explain you the basic difference between ChatGPT and Perplexity. So this is the window for the Perplexity. So what you have to do is you have to pose a question to Perplexity. For example, in this case, I have posed a question, what do you know about acute pulmonary edema? And Perplexity will give us summarized version of acute pulmonary edema, in which it will tell us about what is acute pulmonary edema, what are the signs and symptoms of acute pulmonary edema. And then it will also provide different sources from which Perplexity has obtained this information. And you can click on these resources, and then you can have the detailed version of the resource, and you can read the full text article. So this is the main difference between ChatGPT and Perplexity. In Perplexity, you have first the concise version, and when you can click on the concise version, you can have the detailed version, and you can read the detailed version as well. Next interesting software that I would like to explain you is UPT. UPT will convert any text into a quiz automatically. So it creates questions and answers based on the text submitted, and you can generate quizzes through UPT, and you can export those quizzes into flashcards or quiz tools. What you have to do is you just have to copy and paste some part of your presentation slides, or you want to copy paste some part of textbook into UPT, and you will just have to click generate button, and UPT will generate a quiz automatically for you. So UPT also comes as a free tool and as a paid tool. So paid tool is not very expensive. It costs you around $3 per month. I have also given a link for the UPT. You can go to that link and you can try yourself how useful UPT is. So there is a demonstration of how UPT works. So what I have done, this is the desktop version of the UPT. And what I did is I just copy and paste one of my slide presentation into UPT, which is about severity of the heart failure. So severity of the heart failure is our class 1 heart failure, class 2 heart failure. And then I click the button generate quiz. And what UPT will do, UPT will generate a quiz from one of my slides, which I have just pasted in UPT. So you can see it was just a simple slide, which I have copy pasted into UPT. And UPT has generated a number of questions for me. And not only UPT has generated questions, but it has also generated answers for me. So I can use this quiz during my class presentation, during discussion, or to engage my audience in my presentation. So it is an excellent tool. And you can see, like with one slide, UPT has generated quiz, like what are the different classes of heart failure severity? And it has come up with answer to this quiz. And what are the symptoms of class 2 heart failure? And it has come answer with slight limitation of ordinary activities, which results in fatigue and palpitation. So with UPT, you can have as many quizzes as you want for your class presentation, for your discussion, and for anything. Next important software that I would like to present in front of you, and is an excellent artificial intelligence tool, is PowerPoint Speaker Coach. So Speaker Coach is something which evaluates your pacing, your pitch, your use of filler words, culturally sensitive terms, and it detects when you are being overly wording. So what you need to do is you just, when you are presenting something, or when you want to do practice of something, you just need to click PowerPoint Speaker Coach, and Speaker Coach will record your whole presentation. And not only it will give you live feedback on your presentation, but at the end of your presentation, it will provide you a summary of your presentation, like where you were too quiet, where you were too fast, where your pronunciation was good, where you need to improve yourself. So so PowerPoint Speaker Coach is an excellent artificial intelligence tool, and you can use it before going to conferences, before giving any presentation, if you want to see how your presentation is going. So I have also given a link, and let me show you how you can switch PowerPoint speaker coach during your presentation. So for example, I want to give a presentation on search strategy design for systematic reviews. So I'll open my presentation in PowerPoint. And after opening my presentation in PowerPoint, I'll just go to slide show. And in the slideshow, there is a button which is rehearse with coach. So I have to click this button, rehearse with coach, and then I'll do my presentation as I'm doing in front of audience. And then rehearse with coach will give me a live feedback of my presentation. And not only it will give live feedback of my presentation, but at the end of the presentation, it will come up with a summary of my presentation. So it is an excellent tool for all of you to go through and enjoy. Next important artificial intelligence tool, which we can use in academia, is QueryPod. QueryPod is excellent as an interactive slide deck. So you can have live polls, you can have word clouds, you can have open-ended questions. It can also work as a drawing tool. So once you have a slide deck, which seems to generate about 9 to 12 slides, you can add it and just adjust to suits your need. And plus you can have more slides on QueryPod. Again, it is a premium tool, which means it has a free version and a paid version. Paid version costs you around $15 per month, but it is an excellent tool for teachers who are teaching in their classroom and they want to engage their learners with them. So I have given a link, you can check it out, and you can use QueryPod during your live presentations and during your teaching in your classrooms. So this is QueryPod. You can see that this is a desktop version of the QueryPod, and there are certain activities like you can have discussion questions, you can have time prompt, and you can ask a poll. So if I want to ask a poll, I just enter a question into it, and I'll ask it to generate a poll for me. So what QueryPod will do, it will generate a poll for me. And what I'll do, I'll ask my class to enter into the web page query.live, where they just have to enter a pin, and that pin is given here. So when they will enter a pin, they have a question in front of them, and they can start polling for that question, and you will have live results in your presentation. So this is an excellent tool to engage your audience during your presentation. Next important artificial intelligence tool, which you can use during your in academia and medical writing, is QuillBot. So QuillBot helps you to paraphrase or rewrite text, it analyzes synonyms, and it helps you with fluency, vocabulary, tone, and style. So you just have to paste some text into QuillBot, and it paraphrases it for you. Again, it's a premium tool. It has a free version and a paid version. Although the free version offers you only 125 words in a paraphrase, but the paid version is excellent, and you can use these paid versions if you are more into thesis writing, into academic writing, into medical writing. I have given a link in the, you can check it out, and you can choose QuillBot for your medical writing as well. So let me show how QuillBot works. So for example, if you have written an email to someone and you are not satisfied with its language, what you can do, you can just copy paste your email into QuillBot. For example, in this case, I have written an email and I'm asking QuillBot to paraphrase this for me. Like, hi Sundar, I'm unable to open the links due to limited access to the core system. Can you please send them to me through an alternative method? And what QuillBot has done, it has rephrased that email into another style, which is hello Sundar. Due to my restricted access to the core system, I'm now unable to open the links. Please transmit them to me in a different way if possible. So here you can see it's the same message, and it consists of 2 lines, but you know how it has presented it way is completely different. So if you want to paraphrase something, if you don't like something and you want it to be changed, you can use full board for this purpose. Next important artificial intelligence software that you can use in academia is Slide AI. It's an excellent software, and what you have to do is if you want to make a presentation on something, you are short of time, what you have to do is you have to just copy paste some of your text into Slide AI, and Slide AI will make a presentation for it. Not only it will make a presentation for you, it adds diagrams into your presentation. It can add charts into your presentation, and you can edit those things according to your need as well. So again, it's a premium tool, means there is a free version. From free version, you can make a presentation, about 3 presentations in a month with 2,500 characters. But the paid version is an excellent version from which you can make unlimited presentations. Let me show you how Slides AI work. So this is the desktop version of the Slide AI. So for example, if I want to give a presentation on a topic like women's health, so what I did, I just copy paste some of the material from Google into the Slide AI, and I told the Slide AI software that it's an educational presentation, and I click that adds title, add images, summarize the text, and then I'll just create the option of the slide. So what Slide AI will do, it will take some time and it will generate a presentation for me. So you just have to cross it and the presentation is in front of you. Just you can see I just pasted only one paragraph, and through that 1 or 2 paragraphs, it has created a beautiful presentation for me. And it has not only created a presentation, it has added charts into it. So you can, make any presentation from Slide AI by just copy pasting simple material into Slide AI, and you can edit that presentation according to your needs. So it's an excellent software to be used in academia, and you can use it. I have given the link for this AI tool. You can go and check it out yourself how effective this tool is. Speechify is another excellent tool that is used in academia and for medical writing. What Speechify do? Speechify converts text, which is in the document form, in the PDF form, in the web page, or in the form of a book. You can just have to upload their document into Speechify, and Speechify can convert this text into a speech tool. So if you are more of a listener, or if you more like to learn through listening things, Speechify is an excellent tool for you. If you are traveling, you are going somewhere, you want to listen to something, you want to listen to a medical research paper, you want to listen to some book, you want to listen to some text material, you just have to upload that thing into Speechify, and Speechify will read that text for you, and you can listen and you can learn from that text. I have given the link for the Speechify, and let me show you a demonstration how Speechify works. So what I have done, I have just copy paste some of the material into Speechify box. Just click the play button. So here you can see how Speechify converts the text into speech. So if you want to listen to something, you are traveling, you don't have time, you want to listen, so you just have to upload your medical document, your book, your any article into Speechify, and Speechify will convert that article into a speak version of it, and you can listen and you can learn from it. So it is an excellent tool. So the next interesting tool is DAL-E. DAL is another tool which is formed by the same company which has made ChatGPT, and DAL is a new AI system that can create realistic images and art from a description. So whatever is in your imagination, whatever you think and you want to convert it into a picture form, into a cartoon form, you just have to tell DAL-E and it will convert it into a pictorial form for you. And because it is still in the running, in the trial state, so it is freely available and you can use it for this purpose. So let me show you a demonstration of DAL-E. So for example, someone has given an input, an astronaut riding a horse in photorealistic style. So it will click and the DAL-E will generate an image in front of you. So whatever your imagination is and you want to put that imagination into pictorial form, this is an excellent platform for you. I have given the link. You can go and check it out, how it works. Next interesting artificial intelligence tool that you can use in academia is random face generator. So this artificial intelligence tool allows you to create pictures of the human being who really does not exist. So you can use these images in your writing prompts, in your, if you want to present a clinical case scenario in your class, you can use these pictures and you can use it for your student projects. You just have to provide some simple information like gender, age, wage, and ethnicity, and it will generate a real human face image for you, which really does not exist. So there will be no ethical concerns for that. So let me show how random face generator works. So for example, I just put age or gender of male and age of greater than 50 years, ethnicity Middle Eastern, and I'll just refresh the image. Here it is. So you can see according to gender, age, and ethnicity, which I have provided to random face generator, it has created a face of the human being that really does not exist. And I can use this in my clinical case scenarios. I can use it in student projects, and I can use in my presentations. So it is an excellent tool which you can use in academia. I have given the link and you can check it out yourself, how it works, and you can make any face of your choice which you want to include in your case scenario. Next interesting artificial intelligence tool, which is very interesting and very effective, is an Otter. Otter is basically an artificial intelligence meeting assistant tool that records audio, it writes notes automatically, it captures slides, it generates summaries. Basically, if you are in a meeting, for example, if you are in Zoom meeting, team meetings, Google meeting, and you have connect Otter with your Zoom, Teams, and Google Meet. So what Otter will do, Otter will automatically record those meetings, those presentations, and at the end of the presentations, Otter will come up with transcription. It will summarize the meeting points for you. So Otter is an excellent tool which you can use. It has a basic plan which provides around 300 monthly transcriptions, but it has a paid version as well. So I have given a link to the Otter. You can go, you can check it out. You can attach Otter with your Zoom, Teams, and Google Meet, and Otter will automatically record your meetings and provide transcriptions for your meetings. So you don't have to make more notes for your meetings and waste your time on it. Next interesting artificial intelligence tool, which is very interesting and students really like it, is Hello History. So this artificial intelligence tool works on mobile app. It's a mobile app basically. And through this artificial intelligence tool, you can have a famous personalities' perspectives on life. So if you download this Hello History tool into your mobile, and you want to talk to a famous personality from the past, for example, you want to talk to Einstein, you just click the Einstein button and you ask questions to Mr. Einstein, and he will reply you as he is Einstein. So it's an excellent artificial intelligence tool. You can go, you can chat with your famous personalities, and you really enjoyed it, because when I use this Hello History app in my mobile, I really enjoyed it. So I have given a link to Hello History. You can go, you can check it out yourself, how interesting and how beautiful this artificial intelligence tool is. Next artificial intelligence tool that I would like to present in front of you is Question Well. So Question Well generates an endless supply of questions to teachers, and what you have to do is you just have to, copy paste some of the material from your presentation, from some PDF file, from book into a Question Well, and Question Well will generate endless questions for you. Not only it will generate questions for you, but it will also come up with possible explanation and answers to you. So it's a free tool, and it is very effective tool for students, because if students have learned something and they want to see how they stand in their learning, they can copy paste that learning material into Question Well, and they can generate questions, and then through those questions they can do quizzes and see where they stand, how much they score, and how much they have learned. So I have a free demonstration of Question Well for you people as well. For example, if you want to make question on a topic like diabetes mellitus, so what I have did, I have inserted a topic of diabetes mellitus here. I took some material from the book, I pasted it in Question Well, and you can make your learning outcomes that from this material you want these things students to learn, and you will generate you will click the generate button, and it will take some time, but the Question Well will come up with endless number of questions for you. And not only it will make multiple choice questions for you, it will also give answers to those questions. So this is an excellent artificial intelligence tool which facilitators can use during their teaching sessions, and learners can also use to see to practice on some topic, and it's freely available, so anyone can use it. I have given a link of this tool. You can go and you can check yourself how effective this tool is for academia. Thank you so much. I hope you like my presentation, and I've given my email. If there are certain questions that would not be addressed here, you can email me, and I will definitely would like to reply you in the best of my capacity. Thank you so much.
We thanks to you, dear Tariq. It was a very excellent presentation, because recently everybody is using a little bit these, especially not only the academic staff maybe, but the students, these artificial intelligence tools. So by clicking just at one link, they are generating interesting things and very important things, in fact. So even as you showed there, you just put a paragraph there and you get the questions.
Yeah.
So it's very easy, but of course, in another question, that ethical consideration also very right there, because while you were already presenting your topic in the chat, there was a question which was related with that to you. I just would like to read that. It is in the chat. Dear Professor, what are the implications of artificial intelligence generated content in terms of peer review, scientific rigor, and credibility of academic and medical publications?
So this is an excellent question. Basically, artificial intelligence is a new technology, and we are still making some rules and regulations. And because artificial intelligence is playing so much role in academic and medical writing, so universities are now coming up with new rules and regulations like how much we can include plagiarism from artificial intelligence, because artificial intelligence is something to help us out.
Exactly.
And if it's making our work easier, then why shouldn't we use it? But definitely we need to make certain rules. We need to make certain guidelines. So universities are coming up with guidelines, and the problems they are facing, they are rewriting those guidelines. So yes, there are concerns and there are implications of artificial intelligence in academic writing, but if we stick to those guidelines, if we follow those guidelines, then I think, and if we use these softwares in their true spirit, then I'm sure that there will be no problem and there will be no ethical concerns while using these artificial intelligence tools.
Exactly, I agree with you. Well, all of the words that you said now. And another question that comes from the class that our student there now: how can artificial intelligence be used to enhance the quality and accuracy of citations and references in academic and medical writing, reducing errors and ensuring proper attribution? Okay,
so I think it's an excellent question. There are certain artificial intelligence tools that are like in way of development that will provide more accurate references, because now what the problem everyone is facing, the artificial intelligence tool, the references they are providing, they are not accurate. So even if you are taking something from artificial intelligence, it is always better to go and check if the reference is accurate or not, because till now there is no software that is providing 100% accurate information. So, and because scientific article is very sensitive, so if you are putting some reference in your thesis, in your medical writing, it is always advisable to go and second check that this reference really exists and what you have taken from that article is really present in that reference. So till there are artificial intelligence tools that are still in making, in process of making, who gives us 100% accurate references, it is advisable to check those references if you are putting it into your medical writing. But I think we are not far from the time that there will be certain artificial intelligence tools that will give us 100% accurate references, and we don't have to go and check them again.
Exactly. So another one, thank you for your reply. How can artificial intelligence be employed to facilitate collaboration among researchers and authors from diverse geographical locations, promoting international knowledge exchange and interdisciplinary research? Do you have any idea about, or do you would like to add something in this manner?
I think we can use artificial intelligence to, like, this is a very broad question. Artificial intelligence tools, some of the artificial intelligence tools are already being used, like Otter.
Exactly, yes.
Yes, because Otter is a tool which I told you that can, record meetings. So like if this is a conference and we, just attach this conference to the Otter artificial intelligence tool, so it will automatically record our presentations from different parts of the world. Some is in UK, some is in Turkey, some is in Pakistan. So Otter is basically recording every one of us, and it will, at the end of this conference, it will provide a summary of whole conference, that this presenter was from Pakistan, this presenter was from Turkey. So there are already different artificial intelligence tools that are being used, and it is covering the whole globe, and there will be more which will come in future as well. So I think it's good that that we are using artificial intelligence tools. Similarly, there is robotic surgery, and the future is like you are sitting in UK and you are doing a robotic surgery, even if somewhere it is in practice, like you are sitting in UK and through your computer screen, you are seeing a patient in Turkey and you are doing your surgery from UK. So artificial intelligence is on a high ride, technology is evolving, and we have to adapt ourselves into this technology so that, we can move with the pace of the world. This is very necessary.
Thank you, Professor, and the students already thanks a lot for reply. There are another question, but of course, due to the time, I will not continue because you already write your email address. And I know that you are now also working as a researcher, also a postdoc fellow at the Birmingham University, as I know now currently.
Yeah.
So if the students have another question beside artificial intelligence, maybe because they are Faculty of Medicine, Health Sciences students, so maybe they can contact with you in the future or send an email, or we are going to invite you in our university in the future face-to-face. So hope we will see all of our speakers here already. And thank you again for being here and sharing your knowledge with us today.
Thank you so much, Atta. You were excellent and you are doing a great job. Your university is doing a great job. And I'm honored and obliged to be invited as a guest speaker. And I congratulate you for organizing this excellent conference. And I'm sure everyone will benefit from it. Thank you so much, Atta.
Thank you very much. And I would like to mention again, because without you, this conference couldn't be, of course, realized. But by your help, by accepting our invitation, and of course, with the help of our professors, academic staff, international office, we have the chance to do this one. And I think that I believe that most of our students has gained a lot of knowledge from this symposium. So now we are going to give a lunch break for 1 hour, and then we will continue with our two esteemed guest speakers, April Pike and Beatriz, and then we will go again. Thank you again for being here.
Thank you.
Thank you. And yes, Professor, welcome again. I don't remember that. Did you have time to come yesterday in the symposium in the opening speeches to check a little bit about them? Do you hear me, Professor Anna? No, your voice is not coming to us.
Oh, sorry. I
Welcome again. And you know, yesterday we had some opening speeches, and of course, due to the time difference, you couldn't have time already to log in. And for today, we have one of our international coordinators who does a lot in our university. I just would like to introduce her because she is today with us, and she would like to say welcome to our guest today. Ayşe Deniz Özkan is here with us. Maybe you would like to say something, Ayşe Deniz Hanım. Maybe I think that you know each other, in fact.
Hello, and on behalf of Istanbul ID University International Office, I would like to welcome all our speakers and the audience who are participating in our conference today. Of course, the workload of the preparation of the conference was with the Faculty of Medicine and especially with Atta. But as the international office, we are always ready to help to spread out the word, to disseminate the invitation to all our international partners so they can participate in our scientific activities as well. So we are very thankful that our partner universities from all around the world can join some of our events like this, especially this one. So I would like to thank you and welcome you virtually at least. And hopefully in the coming years, when this conference becomes traditional, so every year it's going to happen, hopefully there will be more face-to-face activities as well in the future so that we can welcome you on our campus physically and take you around our campus and show you our facilities, laboratories. I hope maybe next year.
Thank you a lot, dear Özkan.
And I wish you a very successful conference. And again, thank you all for your participation.
Thank you, Dr. Özkan. Also, Şegül Kaptan, although the Dean of the Faculty of Health Sciences is here, also she contributed a lot together with me in realization of this conference, together with the international office, and that you help us to find our esteemed guest and speaker here today. So thank you again for being here. And we will start with our next speaker, Professor Dr. Beatriz today. And before starting, I will share a little bit information about our professor before the presentation that she's going to do today with us. Yes, I think that my screen is already visible. Yes, today's our next speaker is Professor Dr. Beatriz Gorini da Veiga. And the professor graduated from Biological Sciences in 1999 from Federal University of Rio Grande do Sul in Brazil. And after that, professor continued in the Cellular and Molecular Biology for master degree in the Biotechnology Center at the same university, and completed the PhD program again in the Cellular and Molecular Biology in 2005 at the same institution. Besides that, we have the academic career, because when I was checking that, it was a huge one. Of course, I could not put all of them here, but if you would like to add something, you are welcome. So as a graduate student, she worked again in the cellular and molecular biology for 5 years at the Federal University of Rio Grande. And then as a researcher, postgraduate program, sandwich PhD program at the National Institute of Health in the USA for 2 years. And then, as a senior researcher, postdoctoral fellow in the Department of the Microbiology in the School of Medicine at Mount Sinai, USA, again for over two years. And continue to work. Of course, there is no only one project, but as I checked, it was 2 or 3 projects that the professor worked and consulted in the Griffin Scientific, I think, Institute in this aspect. And she is currently, since 2006, in the Genetic, Cellular, and Molecular Biology Department, working as a professor at the Federal University of Health Sciences of Porto, Alegre. Besides academic career, professor also was working as a former coordinator in the Center of Technology Innovation in Health in the University of Health Sciences of Porto Alegre at the same university for over 5 or 6 years. And the research expertise of the professor, and I will introduce to all of us, our students, if they are interested in these such fields, especially the professor's research field is One Health, One Global Health Approach, Bioinformatics, together with Genomic Epidemiology, Respiratory Viruses, Innovative Intellectual Property. And when we check about the research productivity, of course, we see that we have a young researcher here, a professor here, in fact, and has over 1,565 citations with a high index. And again, I would like to thank a lot for being here today, Professor, with us. She is going to share her knowledge with us. And welcome again to our symposium, Professor Dr. Beatriz. I will stop my sharing and I will let you to share your presentation, Professor. And welcome again.
Thank you very much for the introduction, but most of all, thank you for the invitation to be, to speak on this meeting. And I think it's such an important issue that we are going to talk about here, which is global health in different settings, how it is important for public health, global public health, and most of all, education. How we can contribute for education worldwide and forming students and professionals to tackle the most important issues regarding global public health in the world. So I'm going to share my screen. Let me know. I'm going to share the desktop. So probably I'm not going to see you. After
you can open your PowerPoint on your desktop, and then already you can share your PowerPoint presentation with us.
Okay. Can you see it?
No.
PowerPoint. Share. Oops. Is it sharing my PowerPoint?
No, now it's not sharing. Did you
And
open
now?
your PowerPoint normally?
Is it sharing now? No,
No.
I'm not really used with the Zoom. Sorry about that.
No, we have time. Did you open your presentation in your
Yes,
now?
it is open.
Okay.
Oh, I need to allow Zoom. Okay,
No.
now we
Yes,
go.
you can do that.
Because I need to allow Zoom to see my screen.
Yes.
Can you see
make
now?
Yes, we can see it now.
Okay,
You can make a full screen if it's
like that?
Yes, like
Can you
that.
see
It's
the full
best.
screen, or are you seeing your faces on the side?
No, we are seeing all the full screen here.
Okay, good. So let me know if there's any problem, please. So the title of my presentation, again, thanks again, Atta and all the organization committee and the international office of the university and the Dean of Research and Graduate Students and Education. I'm from the Federal University of Health Sciences in Porto Alegre, which is also a university focused, as the name says, focus on health, on human health studies. We have different undergraduate and postgraduate courses. And the title of my presentation today is The Genomic Epidemiology in the Context of Global Health. So this is going to be the agenda. I'm going to talk a little bit about molecular epidemiology, about genomic epidemiology, how it is related to the study of infectious disease, how the COVID-19 pandemic and other pandemics are examples of the importance of genomic epidemiology for global health. I'm going to talk about genomic surveillance, the importance of doing genomic surveillance, some of the applications. And I'm also going to give examples of some studies that we've been conducting in the past 10, 12 years, such as genomic surveillance of influenza virus, SARS-CoV-2, arboviral disease, and most recently, monkeypox virus. Before I start to talk about molecular epidemiology, let's think about the main cause of the burden of disease in the world. So even though we've been observing a change in epidemiological transaction from having infectious disease as the main cause of death in the world, in a transition to more chronic or other disease, non-communicable disease, we still have infectious disease as an important cause of death worldwide. And if we look here, these are the main cause of deaths in the world from 2000 to 2016. As you see again, we are having this transition, but if we take a look at low, middle income countries, especially in the African continent, we can see that infectious disease are still a really big health problem. And just for you to have an idea, more than 2,000 children die daily of diarrhea. And that's mainly because of bad sanitation, bad water quality. And that's an example how important it is to tackle infectious disease still in the 21st century. So what is molecular epidemiology? I'm bringing here 3 examples of papers. This is from 1996, 1998, and this one here is already from 2000 that talk about the molecular epidemiology, applications of nucleic acid amplification, sequence analysis, and other types of molecular assays to study the epidemiology of infectious disease. And this is another great example from 1996. This paper describes an outbreak of respiratory illness of unknown etiology occurring in some patients. That more than 75% of these patients died. And after analyzing some of the patients' samples, they realized they had antibodies against hantavirus. But viral isolation takes a long time. And so they used another approach, which was to analyze the sample, the viral nucleic acid. And after sequencing, and doing all these genomic comparisons, genomic analysis, they realized it was a totally new hantavirus. This is very similar to what we experienced at the end of 2019 when SARS-CoV-2 emerged and we had the COVID-19 pandemic. So we had we all know the story behind the emergence of SARS-CoV-2. And however, even before that, this was a paper submitted in December 2018, published in February 2019, when some research groups were already studying the molecular epidemiology of coronavirus, especially SARS, the coronavirus that caused a very expressive, severe epidemic in Asia at the end of 2002, beginning of 2003. So many research groups were already studying coronavirus as an important virus with epidemic and, most importantly, pandemic potential. So what is genomic epidemiology? Well, I was showing examples of molecular epidemiology, but with all these advances in molecular biology, now we are able to do genomic epidemiology, which is the application of molecular biology techniques, mainly sequencing, for the study high-throughput sequencing, or also known as next sequencing generation NSG tools, to study the whole genome of pathogenic agents, such as viruses, fungi, bacteria, and other protozoa. So it is the use of these high-throughput sequencing technologies to investigate the disease and spread of infection agents and to mitigate disease in the population. Oops. So the global map here showing the main hotspots of emerging disease in the past, emerging infectious disease in the past years in humans. As you can see here, we've had emerging infections in different parts of the world. They can be either newly identified infections, such as coronavirus, or disease spreading to new areas, such as the Zika virus here in Brazil, and then spreading to the whole South America in 2015, 2016. And also emerging infection and disease spread to other parts of the world. So we have different examples here, like monkeypox that has been around for more than 20 years, and we had a really important epidemic last year. We have Ebola here in Northwest Africa, as I mentioned, Zika and other arboviral disease, dengue worldwide, and many other examples. COVID-19 could not be a better example as a nowadays pandemic. So it was the second pandemic of the 21st century. The first one was the H1N1, the influenza virus pandemic back in 2009. But COVID is a totally like unexpected pandemic regarding the cause of the pandemic, which was the coronavirus. It was the first time that a coronavirus pandemic is really reported in human history. And because of the dimension it took, not only in health burden, but also economic burden throughout the world. This is how it always started, very similar to that paper about hantavirus, but it was not limited to Asia. It ended up spreading all over, and we are all affected, either in health aspects, like not only health, but mental health aspects, but also economical aspects. This is a timeline of the first months or first weeks of COVID-19, the emergence of SARS-CoV-2 at the end of 2019. And then thanks to all this next generation sequencing, to all this very recent advance in molecular biology and bioinformatic tools, scientists were able to sequence the coronavirus genome, do all the analysis, and describe it as a totally new coronavirus. And so this was the situation. I gave a talk on the first week of March here. This is March 5th in our university, showing how was the situation of COVID back in March 2020. We had less than 98,000 cases and less than 3,500 deaths worldwide. And back then, only one case had been reported in Brazil. 3 years later, when the WHO started to update this site on Johns Hopkins webpage, this was the situation. March 2023 here, we had almost 700 million cases and almost 7 million deaths caused by coronavirus. And the main reason why we were able to control the disease was vaccination. So I'm sorry to say this, COVID is neither the first nor the last pandemic that we are going to face. As this infographic shows, we've been dealing with pandemics since back 5,000 years before Christ. So really bad epidemics in China, then we had all the plagues, Athens, Justinian, here smallpox epidemic in Japan, then the Black Death along the Middle Age. So for you to have an idea, even though it shows here 1347, 1351, the bubonic plague emerged here in 1347, but it was not controlled until 1740 something. So this was about 400 years of pandemic caused by Yersinia pestis, which is a bacteria that is still circulating. I mean, of course, it's been controlled, but many wildlife animals still are still reservoirs for Yersinia pestis. Then smallpox at the end here of the middle of 16th century. And thanks to vaccines, antibiotics, and sanitation measures, we were able to control most of the bacterial pandemics. However, on the other hand side, we're facing pandemics caused by viruses. So the worst one here was the Spanish flu at the beginning of the 20th century, 1918, 1919. So this was caused by influenza, but back then, the influenza virus was not even known. People believed that this was caused by some type of bacteria that was causing all the pneumonia and all the deaths. Only in the on the 1930s, that influenza virus was discovered. And then samples back from these patients, they were analyzed, and then the WHO realized that the Spanish flu was caused by influenza virus. And since then, we've been facing different influenza emergence, different subtypes emerging and causing epidemics, and even the 2009 pandemics. And another thing that we have to always remember, HIV that emerged in humans in the 80s is still a pandemic. And SARS-CoV-2, even though it's not a public health emergency anymore, it's still a pandemic. It's still among us. So recent viral pandemics here, mostly the same information as the last one, but this one here is focusing on viral pandemics. Most of them caused by respiratory viruses, such as influenza, coronavirus, and other, even Ebola, even though it's not a respiratory virus, it can be transmitted through respiratory droplets. for you to have an idea about the global burden, the global number of deaths from influenza pandemics. As I mentioned, this was the most important one in the 20s, but other influenza epidemics and pandemics here. And because of the importance of influenza virus for global health, the World Health Organization launched in 1947 the Global Influenza Program, which is focused on the surveillance of respiratory infection to verify, to analyze if those respiratory infection cases are caused by influenza. And with that, they can plan actions to control disease, to develop vaccines, to recommend vaccines, as I'm going to show later on. So in the 50s, different countries established national influenza centers. So these are laboratories situated in different countries. They're responsible for collecting samples from respiratory infection, detecting the presence of influenza virus, either A or B virus, and then sending this information to the World Health Organization. With the internet advances in 1987, the FluNet was created, which is like a gene bank, but especially for influenza viral genomic sequencing. Because of the SARS, the coronavirus in 2002, 2003, the World Health Organization launched the SARS alert, which means that any case of pneumonia with hospitalization of the patient that is negative for influenza or any other known virus, such as respiratory syncytial virus, parainfluenza, it has to be analyzed for the presence of coronavirus. Thanks to that they were able to find out that the cases of pneumonia at the end of 2019 were caused by a coronavirus. Then this program was a little more like expanded in 2011, including the genomic surveillance, not only laboratory detection, but also sequencing and genomic analysis of the samples. And the respiratory syncytial virus was included in the program in 2017. So as you can see here, surveillance based either on clinical information or laboratory diagnosis or even genomic analysis is of paramount importance for the control of infectious disease. But what is genomic surveillance? It involves constantly, not only when something happens, but when like a large amount of deaths are observed, but also a systemic surveillance of cases of respiratory infection and even like arboviral infection, hemorrhagic fever. So it means like sample collection, viral or bacteria analysis based on genomic sequencing. You don't need to isolate the virus. You can, or the bacteria, you can use specific primers to amplify the genomes, or even do with the next generation sequencing. You can also do metagenomic analysis to identify potential infectious organisms in the samples. And with that, we can contribute to monitor disease, control pathogens, think about new antivirals, new vaccines, the development of new antivirals and vaccines to treat patients or for prophylaxis, and also control and even maybe eradicate the disease, such as happened with the smallpox. So why is it important? It's important to combine epidemiological data with clinical and laboratory data with all these other molecular data. Here are other examples of use of viral sequencing data, now here focusing with a focus on viral research. As we were able to do with SARS-CoV-2, we can detect the emergence of new viruses. We can do phylogeography analysis, as I'm going to show next in the next slide. We can do population dynamics, not only of the pathogenic agent in the population, but also understand how the population is moving around, and also analyze pathogen host adaptation. With SARS-CoV-2, this is the new coronavirus, brief example, not example, but a diagram of the genome. Most of the viral genome codes for the polymerase, and 1/3 of the genome codes for other proteins involved in the structure of the virus. It's one of the largest RNA virus that we know. It has about 30,000 bases, RNA nucleotide bases. So based on the sequencing of one of the samples from one of the patients in Wuhan at the end of 2019, they sequenced the viral genome, and then we were able to collect, you know, for this past 3 years, collecting samples from different patients, and then compare this sequence of these other samples with the very first genome analyzed. So for instance, another patient also from China, Guangzhou, the samples collected in February, at the end of February, and we can already see some mutations in the viral genome. Here, another sample from China collected in March, other mutations. And about the same time here, another sample collected from a patient in Belgium, you can see different mutations. So with this type of information, we can trace the dynamics of this virus in different regions. And then we can see how people interact, or if people travel to another place, and how the viral disease was spreading. And this is a phylogenetic analysis comparing the sequence of samples collected in different geographic regions. And with that, we can trace all the route since the virus emerged here in China at the end of 2019, and how it spread to different parts of the world. So this is how we do this type of analysis. Besides that, another important information that the sequencing gives us is what are the parts of the genome, what are the nucleotide positions that are more prone to mutations, which we call like mutation hotspots. So here the size of the bar indicates how many mutations have been observed in that specific nucleotide position. As you can see, some places, some of the genomic positions here have a high mutation rate, whereas other positions, you don't even see mutations. They're more conserved regions in the genome. And why is that important? Because with that, we can plan on designing primers to amplify the conserved regions and make sure this is a coronavirus. If I design a primer that targets places with high mutation rates, if the virus mutate, I cannot see, I cannot fish it, I cannot detect it in a patient sample because the sequence is going to be different. So for diagnostic analysis, it is important that these primers target very conserved regions. On the other hand, if I want to analyze if it's a new variant, then I can design a primer targeting the mutation of that variant specifically. And this is how the first kits were developed. So primers that had as a target the N gene, which is the nucleocapsid protein, the gene that codes for the nucleocapsid protein, or the gene that codes for the envelope protein. This is for the polymerase protein of the virus. And this is how the first diagnostic tests were developed. And probably most of you had to do one of this type of assays here on yourself, even collect a sample, nasal pharyngeal sample. This is the standard analysis of respiratory infection that we do in the lab. So we collect a patient sample, we proceed to nucleic acid extraction. We even, sometimes we also extract not only RNA, but also DNA, because some respiratory viruses, such as adenovirus, have a DNA as a genomic material. Then here for coronavirus, influenza, and other viruses that have RNA, we do our RNA extraction, then we do the reverse transcription followed by quantitative PCR, and then in the thermocycler here, the real-time thermocycler, using these primers, we can see if the patient is positive, if the genomic amplification worked, is because the virus was present in the sample. If not, it was because the sample was negative for that specific virus. And not only for laboratory diagnostics, but as I mentioned, analyzing viral strains is also important. And when this example I'm giving here specifically for influenza, but based on what influenza virus are present in each type of sample, we can submit this information or send this information to the World Health Organization. And based on each type of strains, they're circulating in different regions of the World Health Organization recommends what should be the composition of the vaccine for the Northern Hemisphere and for the Southern Hemisphere. So usually the vaccine must have a strain of influenza A, H1N1, one strain of H3 and 2, and at least one strain of influenza B lineage. If it's a trivalent vaccine, either Yamagata or Victoria lineage. If it's a quadrivalent vaccine, both Yamagata and Victoria lineage of influenza B virus. This here is an example for the Southern Hemisphere 2023 influenza season. This was the composition of the vaccine recommended by the World Health Organization. And this is released at the end of 2022. So that way, we have time to produce the vaccine and apply in the population at the beginning of 2023, like around March, April, we start our vaccination campaigns, which in Brazil is free for the population. Here's for the Northern Hemisphere. So it was launched, it's being launched now, the recommendation for next season. And this should be the composition based on the strains that are circulating worldwide. Also here, not only regarding influenza, but also now for coronavirus that we are seeing all these new vaccine generations, such as RNA-based vaccine, monoclonal antibody vaccines, and so many other types of vaccines that we're having now for COVID to prevent COVID-19. And also treatments. We have examples for influenza like oseltamivir that started to be used for influenza A, H1N1 because the previous adamantines and inhibitors of some proteins, the virus was acquiring resistance to those antivirals. So we started to use oseltamivir, such as Tamiflu, to treat influenza A, H1N1. And the same here for other viral disease, how it is important to understand the viral genome to look for targets for antiviral chemicals and treatments. Now, please let me know how long I still have. I'm not controlling my time, so let me know if I'm late. So here now I'm going to have some examples of genomic epidemiology of viral infections in our state, what I've been working on, what my research group has done in the past years. For those who don't know where I'm located, here's Brazil on the other side of the ocean, of the Atlantic Ocean. And Porto Alegre is located in Rio Grande do Sul here, which is the southernmost state of Brazil. And we have borders of Uruguay, Argentina, and here's the Atlantic Ocean. So as you can see here, we're in the subtropical weather, meaning that we have cold winters with a lot of respiratory infection epidemics, and we are the state with one of the highest incidence of respiratory viruses infection in Brazil. Because of that, I got very interested in studying respiratory viruses. And I started that back in 2009 with the influenza A pandemic, the H1N1 pandemic. And my first studies were more on the epidemiological surveillance, but then I started to do some sequencing and genomic analysis of influenza A virus collected back in 2009, 2010, 2011. And this was the first paper we published back in 2014, showing how the samples from 2011 were already different from the samples from 2009. So this is a phylogenetic analysis showing the evolution of the virus. And we also did some analysis to verify how the vaccine, the 2009 vaccine for influenza, was working the samples. So we found that the vaccine was not as efficient as it was for the viral strain that was circulating back in 2009, showing the need for a vaccine update already in 2011. However, we only had that update in 2016, at the end of 2016. But along those years, I collected samples. And then in 2015, I spent 1 year at the Mount Sinai Hospital in New York City in the United States, sequencing using next generation sequence, which we didn't have back then available in our university. That's one of the reasons I spent 1 year at Mount Sinai. So we did all the sequencing of full genome sequence of influenza virus from 2020 samples from Rio Grande do Sul. And as a matter of fact, these were the first full genome sequence of influenza virus from Brazil deposited in GenBank. And they're available for analysis it's publicly available. And we were able then to publish this paper that came out recently, about 2 months ago, on virus evolution, showing all these epidemics along the years. As you can see, we had a really big epidemic in 2016 before the new vaccine was started to be used. Here is the phylogenetic analysis showing all the samples collected in Rio Grande do Sul compared to samples from other parts of the world, other geographic regions. As you can see, we had this important outbreak in 2016. Not only regarding influenza A, but we also analyzed influenza B in some samples. And in this study, we are able to detect co-infection in patients. So people that were infected by both influenza A and B virus, either influenza A, H3N2 and H1N1, or H3N2 and influenza B, or H1N1 and influenza B. And for the very first time in the literature, we detected a triple infection. A patient that spent more than 3 months, he spent 96 days in the emergency care facility because he was infected. It was a 50-year-old male patient infected with influenza A, H3N2, influenza A, H1N1, and influenza B. Yeah, actually he stayed 97 days. So we characterized all this co-infection. We verified that cardiovascular disease is a very important risk factor for mortality among influenza patients. More recently, we analyzed SARS-CoV-2, the evolution of SARS-CoV-2 in our state, the entrance of different variants, different lineages of SARS-CoV-2. We're able to collect the first 15 cases distributed in the state. So our state has 19 health coordination units. This is more like health authority organization of the health system in the state. So we had the first case collected from each of these regions. We sequenced the SARS-CoV-2 genome from those samples, and we also collected samples from the three main peaks of the first year of the pandemic. So middle of 2020, end of 2020, and then one of the first peaks here in 2021. We also sequenced the samples, and we were able here to verify the dynamic of the lineage SARS-CoV-2 variants that were circulating in the state. With this information, the health state secretariat was able to, or department, was able to determine, to decide for lockdown measures. So every time we found a new variant entering the state, the state health department would establish a lockdown for a certain, like 5-6 days, or would determine which regions were in a red flag that we used to call it, or a green flag or yellow flag, meaning that any type of commercial department or institution could be open in case of a green flag, red flag that everything had shut down, and so on. So that's how we did for the first couple of years of the pandemic. And so here's the same paper showing a phylogenetic analysis, again, comparing with SARS-CoV-2 lineage from different parts of the world. And here, the whole dynamics of lineage occurring in the state. And we also did some mutation analysis of the SARS-CoV-2 spike protein, the gene that codes for the spike protein. And we were able to detect some mutations. They're important because they're either related to more severe disease or resistance to the vaccines. So this was another thing that we did in this study. Now, shifting from respiratory virus to arboviral disease, our study group has also been analyzing recent arbovirus that emerged in the state. Even though we are in Brazil and we have dengue in the country since the 80s, in Rio Grande do Sul, because we are situated far south and because we usually have colder weather, we didn't have any type of autochthonous or endemic arboviral disease until 2007. So 2007, we had the first autochthonous case of dengue. And with all this climate change, and we are having hotter and hotter or warmer winters and summers every year. For instance, now it's winter time here, and we had 37 Celsius last week. And so it's 6 degrees Celsius one day, it goes up to 30 something the next day, and the mosquito is spreading. So we don't have the dengue season anymore. We have it continuously all year round. So we've been analyzing dengue cases and then chikungunya, and back in 2014, 2016, we had the Zika virus. And last year we had in 2021, we had the reemergence of chikungunya virus in the state. So thanks to all the next generation sequencing that we have now in our facilities, we're able to analyze the genomic sequence of these samples, chikungunya from different patient samples in the state, and to verify the lineage that were circulating here in the state. So we combine that information with epidemiological data of the patients, age, sex, main symptoms presented by the patients. And with that, we also use all this information for control and for health measures in the state. And more recently, last year, we had the monkeypox epidemic throughout the country and also in Rio Grande do Sul. And we published this study. This was a case study in which we had a patient that was at home and he needed sample to be collected to verify if he was infected with monkeypox. And then 2 healthcare professionals from the state, 2 nurses, visited the patient to collect samples and to do all the epidemiological analysis. So both nurses, they were wearing the gowns, all the personal protection equipment, masks, gloves, goggles, everything when they visited the patient. So one of the nurses collected blood sample, another nurse collected the sample from the scars. But when they were writing the report at the patient's home, they didn't wear gloves. They only wore gloves when they really had to collect the samples. So they opened the door of the patient house, they closed the door without gloves. They put the samples in an ice box, took it back to the lab. 1 week later, one of the nurses had blisters on her finger. The other nurse had blisters all over her face. So we collected samples from these nurses. They were positive for monkeypox. Then we sequenced the sample from one of the nurses and from the patient. And when we compared with the standard monkeypox genome, we realized that both the patient and the nurse had exactly the same, the virus had exactly the same mutations. In the phylogenetic analysis, they both clustered together here in the phylogenetic tree, showing that most probably the nurse got infected from the patient, not directly from the patient because she didn't touch the patient directly, but probably by touching a surface at the patient home. So this was the first study suggesting a possible contamination through fomites, through contaminated surfaces. And we published that on emerging infectious disease last year, at the end of last year. So with all these examples in this presentation, I want to make it clear that we are every day facing the threat of emerging viral disease. These are examples that we had, but we are gonna have next epidemics and next pandemics coming, especially with such an increase in human population, increase in weather temperature, biodiversity loss, increase in environmental degradation, and so on. There is an epidemic preparedness index for countries to see how each country or each region is prepared to face or to control epidemic disease. So different indicators such as surveillance of cases, immunization of the population, medical workforce, hospital capacity, coordination among different health authorities, be it municipality, state, or country, and even international coordination, physical structure, sanitation, the roads, road qualities, connection among people, institutional capacity, economic resource. We know that a country with high economic resource can recover from a pandemic or from environmental threat much faster than a low-income country. And with that, we can see how each country is prepared. So as you see here, the clearer the color, the more prepared the country is. So Brazil is not doing so bad, especially regarding our population and so many environmental threats that we have. So we are number 2 here in preparedness. Most countries in Africa and Southeast Asia, they're dealing with a very hard capacity in tackling and controlling epidemic disease. Turkey is here in grade 3, so it's in the middle of this index. So as you see, the world has a lot to improve. How can we do that? So some actions we can take to control and prevent infectious disease. We have to take into account the importance of host genetics, the human health, pathogens, environmental health, animal health, if we look from the one health point of view. And so some actions that we are doing: vaccination, environmental sanitation, vector control, sex education. I didn't talk about sexually transmitted disease here, but remember sex education and promoting safe sex, testing and diagnosis, lab surveillance here, food security, infectious disease surveillance, biodiversity preservation, and so many other measures we need to take. So global health and the UN Agenda 2030. How global health is related to the Sustainable Development Goals. So most of you have heard about the 17 development goals, Sustainable Development Goals. Health is here, is directly the issue, the topic of the SDG number 3, but all the SDGs, all the Sustainable Development Goals, they have health related to them, such as addressing consciousness of malnutrition. So this is to end hunger in the world. Education, this is why global health education is so important. This is the role not only of universities, but all the institutions have a role in educating the people. And so all the SDGs here are related directly or indirectly to human health. And this is the decade of action: global action, local action, and people action. So as I like to say, think globally, act locally. In other words, how can you, each one of us, contribute with the global health and the 2030 agenda? And with that, I end my presentation with some pictures of Porto Alegre, where I live, my hometown. This is the park just across the university. This is the river, or actually this is a delta. This is downtown. This is our typical drink. Chimarrão is like a tea that we put hot water. And before the pandemic, we used to share this. Now I'm not sharing my drink with anyone because I'm really afraid of viral disease. And that's it. Thank you very much for your attention. And please, you can contact me. My Instagram is ana.gorini.veiga, and I'm happy to answer any questions. Thank you.
Thanks a lot, and obrigada, like you right there. Teşekkür ederim.
Yeah.
Thanks a lot, Ana Beatriz, for such a beautiful presentation. It was organized and everything was already mentioned there, what we had since 2019, especially pandemic. So thank you again for such a presentation. And I think that the students already have a lot of knowledge by this presentation about the topic that you talked today. And of course, I just would like to mention that when I was checking for the number of genomic sequences that were uploaded in the GSAID database. Maybe you already know that. GSAID, which is the GISA, all the respiratory. Yes, I remember in 2020 from Turkey, 63 genomic sequence, from the Brazil, 92. I just checked already because I know I write something very short paragraph about that. Wondering about that, how many sequences are uploaded. Just for 2 years, from 92, the number of genomic sequences in Brazil, now, as I remember before here, it was 139,000 of the genomic sequences uploaded. So here we see that how already the genomic sequencing analysis already have improved. So, or how the network, as you mentioned, next train, because the people, the scientists already upload everything there, and then they connect with each other and they share this knowledge, and everybody already has the chance to collaborate, I think, with each other. I think that you already uploaded because you talked about the genomic sequences. I think that you already.
So one thing is that for the for influenza virus, since the 80s, 90s, the labs are have been sequencing the hemagglutinin, because the influenza genome is 8 RNA segments. And segment 4 codes for the hemagglutinin protein, segment 6 for the neuraminidase. And those are the age N of the virus. So since the beginning of the surveillance, genomic surveillance of influenza back in the 90s with the FluNet, people are sequencing segment 4 and 6. But we didn't have full genome, influenza genome sequences until of H1N1 until 2016 when we sequenced them. So that's when we deposited them in GenBank, the full genome of influenza H1N1. And the next strain was created with the Zika epidemic. And then it was coordinated with the GSAID, because the GSAID is Global Influenza Surveillance and information, I think, or something. So then it was combined with next strain. And after Zika, next strain also started to be used for influenza, Ebola, and now SARS-CoV-2. And then all these other viruses, genomes started to also be coordinated with GSAID. So now GSAID is not only for influenza anymore, it's for different type of viruses.
Thanks a lot for information. The next speaker is going on. We will go, but I have to ask some question because there are students that are waiting.
I can see a question.
One is there. The first question is related to what ethical considerations and data sharing policies should be followed when conducted global genomic epidemiology research, especially in low and middle income countries. What do you think about that, Prof?
That's a very important question. So what we do, first of all, about epidemiological data, like age, symptoms, we have to make sure we don't have access to the patient name or personal information. We know symptoms, we know demographic data, but we don't know who is who. And regarding the molecular information, the genomic information, we only analyze the viral genomic. We don't do analysis of the human genome. Of course, if we want to do something with the human sample, either being a molecular analysis of only viral disease or either viral genome or human genome, all the projects, they have to be submitted to the research board, ethical board. So regarding the informed consent from the patient, we do that, we use the informed consent if we're going to analyze the patient DNA, which we don't do. Because respiratory infection with hospitalization is of mandatory notification in Brazil. So we have the data, all the information about the number of people that were hospitalized, what were their ages, and the symptoms they presented. So that's the information we have.
Thanks a lot. And one more question as we are at the last minutes. How can international collaboration and partnership facilitate the sharing of genomic data and expertise to address global health challenges? What do you think about that?
Can you repeat that?
How can international collaborations and partnership facilitate the sharing of genomic data and expertise to address global health challenges? What do you think about that? We talked a little bit, but
yeah. So as we experienced with COVID, now with all this easy that it is to go from one part of the world to another part of the world in hours. I can be in Turkey tomorrow night if I want. I just take a flight somewhere and then make a connection tomorrow night, or the next day I can be in Turkey. What if I got infected today with something here in Brazil? I don't have any symptoms yet. I fly, I take, I'm taking an airplane with a lot of people. I make 2-3 connections along the way, and then I arrive in Turkey infected, and then I start to present symptoms. Where I'm coming from? What information do you have about the whole route that I did from Brazil all the way to Istanbul? So that, and then where was the sample collected? Where's this information? Who is going to be the next patient the next person presenting symptoms similar to those symptoms that I am presenting? How important it is to release this information as fast as possible to be able to take control measures, shut down airports, or put this patient in isolation. So that's one of the examples that is important to share information, not only epidemiological information, but genomic information about what virus or bacteria or fungi was infecting that person, what are the risks of being transmitted, like airborne, transmitted to other people, what are the procedures that should be taken. So that's one of the examples. And the faster we have this information available everywhere, the faster we can act to prevent another pandemic. And especially if we think, as I mentioned, different conditions that different countries have to control health threats. And one thing that happens in one country is going to affect the whole world, as we experience with COVID.
Yes.
I don't know if I answered the question.
Yes, the students already sent from the phone because they are in the class watching you there. But of course, if they have another question, they will contact you and ask another question if they are interested in.
And again, I'm very happy, and I really look forward to be able to visit you. Who knows, hopefully next year. I was once in Radu. I was in love with the city. It was such a short time, only 2 days. Didn't have enough time to see and to make collaborations happen.
You are welcome, Professor, and I hope that we will see face-to-face in Istanbul and here in our university and the campus in another conference face-to-face. Thanks again for being part here and sharing your information. Now we are going to continue with another next speaker, who is again talking about the genomics and nursing, Professor Dr. April Pike from the Memorial University from Canada. So thanks again, Professor. Now, before Professor Pike is going to give her presentation, I would like to give a brief information about Professor, especially for our students that are new and for our academic staff that would like to know who is the Professor. Professor April Pike, after completed her bachelor degree in the School of Nursing, continued in the same department, Master and PhD program in the Memorial University in Canada, where her PhD was in the Faculty of Medicine Community Health. And beside after we talk about the education, when we check about the academic career, professor starting working in the Memorial University, Canada as the assistant professor in the School of Nursing, where she continued to work there an associate professor and then as a professor at the same university. Professor also holds another duties where beside academic career, professor also have current administrative duties because already we know that they have a very busy schedule. They are sharing today with us their valuable time. She is also Dean of the Faculty of Nursing since 2022 and Associate Dean of the Research in the Faculty of Nursing at the same university. And the professor's research expertise is especially genetics and risk, cardiovascular disease, qualitative research methods, and hearing loss. And I would like to thank a lot to the Professor April that she is going to be here today with us. So welcome again to our symposium, Professor April. It's your time, yes. You can share your presentation now.
Thank you very much for this prestigious invite. Can you see my presentation?
You can now share it again because I shared the previous one. It already disappears, but you can do it again. Yes, it's now okay. It's a full, yes, it's a full screen.
Full screen? Okay. So I'll start. Thank you very much for taking your time out of your busy schedule. And I spent a lot of time in Turkey. It's one of my favorite places to visit. I spent times with a family in Turkey for like 6 weeks, probably twice a year. So I dearly love that country. And when I got an invitation, I would say absolutely. So I'm going to take a different swing. And I've been in this research space of genomics for, I want to say 20 plus years as a nurse. And it's taken a long time to really develop a program of research that focuses on nursing in genomics. And I'm happy to say in the last 5 years, it's really come to full fruition that nurses and I guess other academics really starting to look and value what nurses bring to the genomic space. So what I'm going to present today is an overview of a program of research that's really building towards the acceleration of the integration of genomics into nursing practice. So although my PhD is in medicine, I still hold, as you can see, I'm the Dean of the Faculty of Nursing, strong roots to nursing. And I'm really excited that it's sort of starting to take off and people are starting to value the position of nursing within the research agenda. And we've been struggling for a while, so thank you. So just a brief disclosure statement, I don't have any conflict of interest. And you will note throughout my presentation that the funding sources are noted on the bottom. We have received funding from the Canadian Institute of Health Research, and we have in Canada, we call Tri-Council. So all this work has been Tri-Council funded. And the work that I'm presenting here is the work of the Canadian Genomics, Nursing Genomics Group. And I'm presenting 5 projects. So I have listed the collaborators and people, other experts that we brought in on our leadership team in order to do the good work. So, but the foundational work is of the CNG, of the Canadian Nurses Genomics Group. So first off, I thought I would show the members of the Canadian Nursing Steering Committee, and it was formed in 2020. And they come from different regions of Canada. So Canada is a very vast geographical plant of a country. I live in a small island called Newfoundland, and alone in Newfoundland, it takes 10 hours to drive across a small province. And we only have 500,000 people. So to drive across Canada would take about 5 days. So you can see the depth and breadth. So we have researchers from all across different universities that are participating as members of the Canadian Nursing Genomics Group. I wanted just to highlight with Dr. Jacqueline Lemos, who's one of the chairs of the steering committee at Athabasca University in Alberta. And as well, down on the bottom in the middle is Rebecca Puttister, is actually my PhD student, and she's doing her work in genomics. So the objective of this presentation is to provide an overview of the work of the Canadian Nursing Genomics, or the CNG group, as we move towards integrating genomics into nursing education, into research, and into practice. So although genomics has been the topic of discussion since the Human Genome Project in the early 1990s, and despite efforts of nurse scholars like myself to sort of trudge forward to integrate genomics into nursing practice, it really truly hasn't come to fruition. The Canadian Nursing Genomics Group recognized the need to respond to the advancements in genomics. Traditionally, genetics was seen as a specialty area focused on relatively rare conditions. Now, genomics is becoming more mainstream. To make our important disciplinary contributions as nurses to genomics-informed healthcare, and to ensure that patients and society can benefit from these genomic advancements, the Canadian nurses must be equipped with knowledge in genomics. Until the work of the CNG, there have been very limited Canadian studies examining nurses' genomic competencies. However, there have been 2 studies, one in 2005 and one in 2020, but they found that nurses have low genomic literacy levels, little formal education in genomics, and lack of confidence to engage in genetic-informed or genomic-informed care. And I know there's also been a lot of work done in Turkey around genetics, and a lot of work done in China, and particularly a lot of work done in the US and the UK. So we, meaning the CNG, have developed a series of labs, and we've used the acronym DESIGN to actually articulate the overall program of research. Design refers to the development and evaluation of strategies to integrate genomics into nursing practice. And what I'm planning on doing today is giving you a brief overview of how we started our design labs and where we're going. And I can be honest, it has not been easy, but we keep merging forward. So here are the 5 design initiatives. The first one is an engagement framework, the development of a website to house our work, the Genetics and Genomics Nursing Practice Survey, and that's actually been done in Turkey. Design policy, where we started to look at policy development, and we actually did a design of a scoping review. So collectively, we're hoping that these projects will help us accelerate the integration of genomics into nursing practice. So the first one I'm going to talk about, and you'll note that, as I said, the funding is on the bottom, and we have a list of the project team here. And this project team are the seminal group that was part of the CNG. And because of time, I'm just going to give a brief glimpse into the projects, but if anyone has any questions, I'm happy that they can circle back and contact me, and I can provide in-depth. So the first really busy slide is our engagement framework. And the purpose of this engagement framework was really to give the group some foundational direction, or to identify priority key strategies that we can develop and build on. As we move through this presentation, you will note that each project is based on the key priorities for nursing that's outlined in the bottom right quadrant. So I'm just going to draw your attention to how we created the engagement framework. And initially, the idea around it was brought to us by the work at a Catholic Zone down out of the US. They did similar works about creating, and out of the UK as well. Emma Tompkins did a lot of work about this, about developing a framework to engage nurses and researchers and policymakers to look at nursing and how we can integrate genomics into our practice. So in the bottom left, when we talk about the title is Building the Engagement Framework, I'm just going to take you through some of the activities that we did to reach the key priorities. The first thing we did was we did an in-depth document analysis and environmental scan of the genetics and genomics in nursing. And we're really looking at what were some of the common strategies to support genomic literacy. We explored a variety of websites across Canada, some professional organizations, and we actually pulled a number of 37 documents. Unfortunately, the findings revealed an overall lack of nursing documents that include content related to genetics and genomics. However, what we noted that there were opportunities to capitalize on for the application of genetics through documents of nursing professional organizations, nursing accredited organizations, and some of our regulatory bodies. We also identified that early adopters such as oncology nurses present opportunities for future research. So oncology nurses were really invested in seeing the relevance of genomics into their practice. We also engaged 27 nurses across the country in virtual sessions aimed at identifying clinical questions. What are some of nurses' knowledge needs? What are some research opportunities? And what are some of the infrastructure required to address the lack of genomics in nursing practice? We also did consultations with international experts in the field. For example, Kathy Calzone and Emma Tompkins, ISON, the G2NA, Oncology Nurses Society, and CANO, which is Canadian Association of Oncology Nurses. Based on this work, we identified 6 key priorities that would drive the work and did drive the subsequent projects that I'm going to talk about. So the priorities for nursing were to engage nurses to see the clinical relevance of genomics. And that seems to be a key issue in the literature, that nurses don't see the relevance of genomics into the practice. But when they attend sessions or education and their awareness is sparked, they start to see the relevance, but they struggle about where to go to get this information. We want to clarify nurses' unique and overlapping roles in genomics, develop knowledge for nursing practice through research, provide education and workforce development, provide innovation and new care pathways with leadership, and create the infrastructure to support professional practice in genomics. So our next projects are really trying to target these key priorities that have been identified from the literature in consultation with key stakeholders and with our virtual sessions that we had with nurses. So what you're seeing here is an article that actually outlines the process of developing the engagement framework, if you're interested in reading about this. And I have the QR code there as well for access. So you can just take a picture and that lead you directly to the article. This as well is an article on how we did the policy document analysis. So if people are interested in really looking at to map out what exists within their country, you can actually follow the way that we did this process. So this has been published as well, and I have the QR code and the citation, and it's in the Canadian Journal of Nursing Research. And this was really imperative to identify who were the early adopters. And some of our researchers really started to focus on those early adopters, which are the oncology nurses. And then we will increase our bandwidth, as per se, to other practice areas. So in Canada, we have no common place like they have in the UK or in the US that nurses can go to glean information about genomics. So we created a website to ground knowledge and education initiatives related to genomics and nursing. And again, this was the key core group of the CNG, and we brought in some web designers as well to help us create this website. It also seeks to highlight the relevance of genomics to nursing, the role of the nurse in genomics, area of collaboration among nurses to accelerate the adoption of genomics into our practice, and really importantly, how genomic informed care can improve client healthcare outcomes. For example, if you go to the website, it features some, we have storyboards, we have videos about foundational genomics terminology. And we have some clinical exemplars or vignettes of nurses and how they're actually integrating genomics into their practice. We also have information about the CNG, research projects, publications are all located on the resource tab. And we are continuing to add to this website. And we're hoping that this website will be a hub for people to access genomic information. Because as I said previously, nurses are struggling where to go. They want one main place that they can get information quickly. So this is our genomics website. I really want to go into the website and show you, but I'm afraid that I won't be able to get back. So unless someone has advanced skills that I don't have. But on the website, you will know there is a variety of storyboards and educational material that you're welcome to use. So the third project is we call it GGNPS-CA, which is Canada. It's a genetic and genomic nursing practice survey. And this survey has actually been done in Turkey as well. It's been done in the US and it's been done in China. So in order to develop target strategies to accelerate the adoption of genomics into nursing practice, we felt that we need to have the evidence or the benchmark data to really move forward to illustrate where nurses are at with respect to these variables. And when we actually do interventions, what to evaluate, what are the behavior or attitudinal changes. So we want to capture the level of knowledge, attitudes, and confidence with genomics. Our team was joined by Kathy Cazone, who actually developed the GGNPS in the US to obtain the same benchmark data of the American cohort of nurses. So the GGNPS is a psychometric instrument that's comprised of 61 items that measures nurses' competence and adoption of genomics, such as their knowledge, attitudes, confidence, and practice. And interesting, the GGNPS was developed so that it could be modified for other countries. And we did that. So we took the GGNPS and we modified it to reflect the Canadian context, and importantly, to address the equity and ethical issues in genomics, because that really wasn't part of the tool. We assessed the modifications with face and content validity and did retest reliability in the convenience sample of Canadian nurses. The end result was the addition of 13 questions being added to the original instrument, and thus we renamed it the GGNPS Canadian, or CA. This cross-sectional descriptive study used diverse digital recruitment strategies to recruit registered nurses, registered psychiatric nurses, registered practical nurses, and nurse practitioners. So this included the distribution of a QR code and a website link through a survey. And we sent the survey out through the email listserv of our nursing regulatory bodies, through graduate programs, and we also sent it out to the websites of professional organizations. For example, in Canada, we have the Canadian Association of Schools of Nursing. The survey data was collected over a 10-week period, and we used both descriptive and inferential statistics to describe the study demographics and the findings. Our team also did some regression modeling to determine predictors of knowledge and confidence scores. I have to come clean. I did not do the statistical analysis. We hired a statistician to do those analysis. So I just want to give you some brief findings of the study. So we have 1,013 respondents. We had representation from all 10 Canadian provinces and 2 of the 3 of Canadian territories. There are a wide range of ages recruited, and the sample was predominantly female. The majority of participants were white, followed by Indigenous, South Asian, Chinese, Black, and Filipino. So with respect to the practice area and qualification, we had representation was primarily from registered nurses, But as I said previously, we also had registered practical, or in some places called licensed practical nurses, nurse practitioners, and registered psychiatric nurses. Our nurses worked in a variety of practice areas, including community care, education, mental health, medicine, oncology, and pediatrics. So nurses believe that being educated by genomics, interactions between the environment, genes, and the ethical issues associated with genomics are really important. However, 91.1% of the nurses indicated that they were either very or somewhat important to become educated by genetics and genomics. 92.6% of nurses reported it was somewhat or important to become more educated about environment and gene interactions. And 91.8% indicated it was important to become more educated about the ethical issues. With respect to their attitudes, we were really encouraged that nurses generally have positive attitudes towards genomic-informed practices. And Canadian nurses see the advantage of genomic-informed practices for nurses. In fact, 86.9% of nurses responded yes when they thought that integrating genomics into their practice would improve treatment decisions. 92.3% indicated that there would be advantage to integrating genomics into their practice to help improve service for patients. And 95.6% indicated there would be a benefit of integrating genetics into practice for identifying individuals who would be enrolled in high screen program. So this is really important because nurses want to be in the space. So when we talk about confidence, the mean confidence score was 5.06 out of 13, with a standard deviation of 4.18, indicating that nurses lack the confidence, and their confidence varies by levels of topics. So 39%, that's pretty low. So we really need to target the nurses and build up their confidence in order to be in this space. Canadian nurses actually reported that they were most confident in considering access to the social determinants of health when interpreting the family history and making recommendations and referrals. They were most confident in collecting and interpreting a family history with sensitivity for diversity, heritage, and family composition. However, they were least confident in facilitating referrals for genetic services, and they were least confident in giving patients information about the risks of genetic testing for common health challenges and the limitations of genetic testing for common health challenges. And this is a bit concerning because one of the main roles of nursing is to provide psychosocial support for these individuals. With respect to the knowledge score, the mean knowledge score was 71.6% with a standard deviation of 1.56. Now, our knowledge score was a little bit higher than that reported in China. China reported 69%, and a little bit higher than that of the US, which reported 67%. But we were lower than Turkey, which reported 78%. Some of these discrepancies we feel can be contributed to the sample size, the differences in the sample. In Canada, the average years of experience of a nurse was greater than 20. In China, it was 3 to 10. In the US, it was 17.6. However, in Turkey, with respect to the sample size, there was more people that participated in the study that had graduate education. So we need to have a little bit more of a closer look at these scores. So greater than 99% correctly answered questions addressing the clinical relevance of genetics for common health conditions. 85.7% identified family history as a key component, but only 26.9% appropriately disagreed that a first-degree family history should be included for new patients. And actually, we should be doing a second and third generation. 52.8% correctly identified the significance of including the second and third degree relatives in identifying their inheritance patterns. Only 28.2% correctly answered a true-false item, that the DNA of sequence of two randomly selected healthy individuals of the same sex are not 90 to 95% identical. 38% knew that diabetes and heart disease are not caused by a single gene variant. 61.8% correctly noted that it's essential to include a family history to support clinical decisions. And 73% ranked their genetic genomic knowledge as poor, 26% as good, and 1% as excellent. So we see we have some work to do with respects to not only respects to confidence in some areas, but actually with the knowledge. So some conclusions that we draw is that nurses recognize the importance of genomics in health decisions, which is good. Patients are initiating conversations about genomics with nurses, which is fantastic. But nurses have not received the support or knowledge to feel comfortable in using genomics in their clinical care. And nurses understand that promoting equity, diversity, and inclusion in genomics can improve the health of Canadians. So some wins and some concerns. So the next big project that we're actually engaging in right now is a policy government funded project that we're actually looking at developing policy and infrastructure to support the acceleration of genomics. And you can see that our team has expanded enormously. And we do have Kathy Calzone and we have Emma Tompkins on our team as well. And we have representation from our educating bodies, CASM, which is Canadian Association of Schools of Nursing, and CANO, which is the Oncology Association. So the spearhead for this project was that we recognize that Canadian nurses need genomic-informed policy to improve patients' health outcomes, better patient and provider experience, increase value, and health equity. Compared to the genomics policy infrastructure in the US and the UK, Canada is underperforming drastically. Really drastically. I can't emphasize that. And this project, as I noted, was really developed to address the lack of policy as one of the key first steps to get nurses working in the space. So the goal of this project was to identify the policy features and what are the really true driving force that have been noted in other countries to integrate genomics in nursing practice. So another busy slide that I'll try to just focus on a few of the key points. This provides an overview of the whole project. So we have a 3-phase project, and the overall goal of the project is to generate relevant evidence and policy options to complement advancement in precision healthcare. So really what we're looking at is what kinds of policy needs to be developed. What should it look like? What are the characteristics? And who should be the driving forces behind it? So I'm going to just go through phase 1 and talk a bit about phase 2. And we're completed phase 1. We're in the middle of phase 2, and we're starting to get our findings in order to move towards phase 3. So in order to complete Objective 1 and phase 1 of the project, we used what we call 3L+E policy framework to identify the key policy features and policy drivers. And when I refer to features, I'm talking about what kinds of policies, like clinical practice guidelines, mission statements, and what are the policy drivers, or what are the interests, the ideals, or what institutions or external factors that influence policy decisions within Canada. And we did a comparative policy analysis and actually looked at these policies and features and policy drivers in the US and in the UK, because they're more mature with respect to this structure. And as I said, phase 1 is completed. And then we took the findings of the review of that policy document, comparative policy document, to inform phase 2, Objective 2. So in phase 2, objective 2, we wanted to do is engage stakeholders to obtain evidence on the policy features. So we took the findings and presented to individuals or stakeholders and said, how does this really resonate with you? What do you think are the policy features and the policy drivers that we really, really need to draw our attention to? So in these interviews, we had nurses from practice, education, research, and primarily in the space of oncology, because these are the early adopters. We also have regulatory bodies, professional associations, and patients included. And now what we're moving into is objective 3, phase 3. So the synthesis of the findings from phase 1 and phase 2, we will actually develop policy recommendations, and particularly policy recommendations to our knowledge users, which is the Canadian Association of Schools of Nursing and the Canadian Oncology Society, as they are the early adopters. So this is what I'm showing now is the findings from objective 1, phase 1 of the study, of the comparison policy analysis of the policies done in the UK and the US. At the center of the diagram, we identified the 4 types of policy documents that we saw that supported the integration of genomics into nursing. So they are position statements and policy advocacy briefs, education frameworks and curriculum frameworks. And when I speak to those in Canada, we have the Canadian Association of Schools of Nursing have identified key standards and objectives that each faculty of nursing are responsible to ensure that the graduates meet before graduating. There are also competence statements and scope of standard documents that are put out by professional regulatory bodies that our graduates have to meet upon graduation. I want to draw your attention now to the outside of the diagram in the 4 corners. These are the policy drivers, or the things that really drive and spark people's interest to get policies on the table. So in the top left corner, we have the ideas. This includes the recognition that we need to prepare nurses with the knowledge and skills and work to lead in genomics. So people are starting really to come to think about what is the role of the nurse. And given the acceleration of technology in this space, nurses must have the requisite skills to provide safe, competent, ethical care. And importantly, to respond to the needs of the patients, because patients are asking nurses about these questions. And we need to be able to respond and support these patients. And a common role of the nurse is to provide psychosocial support. So I think we're doing a little bit of disservice to our nurses right now. And it really, I can understand the knowledge scores that they don't have that lack of confidence. Because when you talk about genomics, you know, we really, is it foundational knowledge, and what really is foundational knowledge, and what is the expectations? So it's our responsibility to provide this for our nurses. So one of the really key ideals was that the public has an expectation that nurses have this knowledge. Another driving factor was strong infrastructure, and that refers to policies, funding for nurses to do research in this space, clinical support tools, nursing education, and collaboration across disciplines to provide this care. Because as we know, genomics is very complex and it doesn't exist in silo. When we refer to the interests at the top right-hand corner, interests were influenced by the presence of strong nursing leadership, professional organizations that are interested in working in this space, interdisciplinary groups, government, health service organization, and funding institutions. And I've been working in this area for quite a long time. And unless it's bench science in genomics, you're not getting funding, and it's a struggle. So I'm really happy to say that we have actually got funding for all of these projects. So I think that's a big win for nursing. On the bottom left-hand corner, in terms of institution, we also found that strong policy networks and infrastructure, again, government, nursing leaders, and academic institutions were needed to support genomics policy development and the integration into nursing practice and education. On the bottom right-hand corner, the external factors included the urgency to prepare nurses given the advancements in genomics, the potential contribution of nurses to healthcare, and to be in alignment with national, global strategic policies and legislation. For example, the U.S. Genetic Information Non-Discrimination Act of 2008. And an interesting side tip is I went to a Canadian Institute of Health Research 3-minute rapid fire. And when I did my presentation around nursing and genomics, afterwards, I was approached by some of the leaders in the CIHR Institute of Genomics and said, we never really thought about nurses in this space, and it's an untapped resource. And it was really a pleasure to see people really starting to see the good contribution that nurses can make within this space. But we need to have the requisite knowledge and skills and the language. So lastly, both countries, meaning the US and the UK, seem to be driven by the work of other disciplines and other jurisdictions. There was evidence of how shifts in scopes among genetic counselors and medical professionals in the US influence nurses and the impact of collaboration to develop interprofessional competencies. Both countries illustrate that learning from other countries was also useful in forming their jurisdictional context. And we're hoping that we can glean the information from the US and the UK and from the findings from China and Turkey to actually develop our infrastructure stronger to support nursing. So the final project that I will talk about is the scoping review. And this is our most recent project. And you heard me talk about at the beginning about the addition of equity questions added to the GGNPS. So we felt we need to have a deeper dive into what are actually some of the strategies being used to inform genomic-informed care. So the goal of this project is to map the available evidence and critically assess the knowledge and equity concerns, social process, and healthcare practices that enable the equitable application of genomic technologies by nurses in healthcare and society at large. In doing this project, we sought to gain a fuller understanding of what strategies nurses were actually using to ensure the equitable application of genomics into their practice. This knowledge, again, we will use to help the development of policies, education, and research programs in genomics with an equity lens. So our review question was, what is the available evidence and how nurses can facilitate genetic and genomics informed healthcare to address health disparities? So really, we're really trying to get a good look at it. What are nurses doing to ensure that they're providing equity in their care? So we used a Johanna Briggs methodological approach, which is out of the Institute in Australia, and we actually brought on somebody with an expertise in that space. And here at Memorial, we are a JBI affiliated institution, so it fit really well with the team. Inclusion criteria was based on population, concept, and content. The population were registered nurses, licensed practical nurses, nurse practitioners across all domains of practice. The concept includes strategies to address health disparities, for example, education, making referrals. And the context was the global literature from all geographic locations that examine strategies to enable nurses to engage in genomic-informed healthcare. Just as an FYI, when we talk about strategies, we're talking about methods, a process, interventions, and tools used by nurses to address and mitigate health disparities. So the types of sources that we use were mainly quant, qual, and gray literature. We also included, of course, mixed methods. We included opinion papers. We didn't include anything that we could not translate into English, and we didn't include, I don't think we'd include dissertations. The majority of papers were discussions. There was about 17 discussion papers. There was only 5 qualitative. We had 4 quant. We had 3 literature reviews, and we had 2 mixed methods. And we did have a vigorous approach with the library and assisted with the search and developing of the search strategy. We screened a total of 702 papers, with 32 meeting the inclusion criteria. Most papers were from 2019 to 2021, majority from the US and the Netherlands, followed by the UK and Tanzania. There were no Canadian papers at all, which is very disappointing. There were a large number of papers, 14, that were related to inequitable access to genetic and genomic services. And they include things like genetic testing, counseling, and doing referrals. Inequitable access was noted for those with lower education and health literacy, lower socioeconomic status, migrants, lack of insurance, and those living in rural and remote regions, and older adults. And this is really important for the Canadian context because we have a large geographical plant, and we provide healthcare service to a large rural population. And Canada is one of the oldest aging population in the world. So this is really hit home for us. The root cause of these inequities varied at the patient, provider, and system level. Poverty, low health literacy, racism, geographic location, poor knowledge of providers, and medical distrust were cited as the most frequent root causes to inequities. So the findings, we identified 2 key findings. The first one was preparing the nursing workforce, and the other one was strategies that nurses can implement in practice to improve patient care. So when we talk about strategies to prepare the workforce, a key strategy noted was to increase access and availability so nurses have a stronger understanding of their role in genomic healthcare, can engage in communication with patients in a safe and culturally sensitive manner, and know when to refer those patients that are at risk. It was clear that access to the most up-to-date information and having genetic informed information throughout all levels of nursing curricula was imperative. This education must include ongoing reflection of implicit biases that may impact equitable care and create more diverse nursing workforce to represent racialized groups. We also noted that we need, of course, to increase nurses in research, encouraging nurses to engage in advocacy and policy to support access, and become knowledgeable about practices, best practices, and legislation. And it is imperative that we have strong nurse leaders to support education and advocacy in communities. And in the US, they have these magnet hospitals, which have a really focused effort on developing leaders and have an internship for students, which has really helped. If you look at some of that literature around magnet hospitals, they've been quite successful in their outcomes. So strategies to implement in practice, of course, is increase supports for nurses, increase nurses' community engagement with key stakeholders and patient education. And we need models of care to increase equitable access, particularly in those areas of rural regions of the country, such as telehealth or technology. Literature alludes to the use of nurse navigators, and my PhD student, Rebecca, is actually looking at the implementation of a nurse navigator in the genomics. Having nurse practitioners lead programs, self-referrals, and being members of interprofessional teams. We need to ensure in our research that there are diversity of research participants, and researchers are embedded in the community to promote trust. And nurses have been known to be one of the most, actually the top professional that actually patients trust. And trust is one of the key things in promoting equity, and particularly within Canada, within the Indigenous community. I'm sure people have heard about the loss of trust in both in healthcare and in the government related to this cohort. So we really take this seriously. And as researchers, we really engage with our communities as members of the research team. And you will note throughout this projects that I'm describing, we have included patients as partners in the research. So policy is really important to ensure equitable access to resources, to reduce biases and promote data sharing, and leadership, of course, is really important. So some of the gaps that we noticed was there's lack of empirical studies or interventional evaluation studies exploring feasibility, impact of strategies on health outcomes. The majority of strategies made broad claims or recommendations, and there was a lack of agreement as to the definition of health inequities and disparities. And in fact, one of the findings, we're actually diving a bit deeper because we're going to be writing a paper on that. This is that nurses make claims that we are providing equitable care, but the evidence there that we did not see evidence in the documents that we looked at to support these claims. So we are going to go back and do another scoping to review to really target that piece. So in summary, all of our 5 design projects, and we hope there are many more, are laying the foundation to accelerate the integration of genetics and genomics into nursing practice, education, and research. So thank you very much for your time. I've given you the links for the Canadian Nurses and Genomics Group. My email is there, and below you will find our funding sources. And I just want to thank you for taking this time to come listen. It's been a hard road to try to get where we're at, but I think our big win is getting to the policy grant and getting the attention of professional nursing organizations. We have the attention of the regulatory bodies and government and the funding bodies. So we're hoping to move this and mobilize this forward.
Thank you, Professor, for your time and for such a there was a fulfilled information here, a lot about nursing and genomics. In fact, I didn't know so much about that. You did a lot of work. There are a lot of projects here that you are going to implement to do that. Thanks again. And now I will check in the chat box. We have here Professor Beatriz here. Also, she talked about the global epidemiology and genomics and has some question. In fact, some I think suggestion, or I just would like to check here. The first one is, I teach molecular biology and genetics to undergraduate students of the first year of nursing degree. It's very hard to make them see the importance of molecular biology in their future practice. What suggestion do you have in this manner?
Yeah, it's really hard to get them. I think if you use what I found in my teaching is that I've used clinical exemplars of how they can translate this knowledge into patient care. So what we've done on our website is actually we've created situations so that nurses can actually see the relevancy. So the early adopters, the oncology nurses, they see this, but new nurses, novice nurses, they don't. So what I would do was I would create an assignment, or I would create a clinical example of how this applies to their practice and something. So once they see the relevancy, they'll have more buy-in.
Thank you, Professor. I will continue because Professor already continued in the same, I think, related question. Professor said again, I'm enjoying this presentation a lot because, as I said above, I teach students that are pursuing a degree in nursing, and it's very hard to make them realize the importance of genomics. And in my opinion, to understand genomics, they need to know the basics of molecular biology and genetics. What is your opinion about in what period of their graduation should they have these classes? I mean, I teach molecular biology and genetics to the first year undergrad. Should they have it later on? About the courses or classes in these subjects, molecular biology and genetics especially.
Absolutely, and I'll just add to that question, because here at Memorial, like I said, I've been here 20 years and I did a presentation about the lack of genomics in nursing education then. And it's gotten no better, I can be honest. But now, through our work, we've actually, and by situating myself on the Canadian Association of Schools of Nursing Board for the curriculum framework, I got the word genomics in there. So now, you know, our faculty of nursing have to teach genomics. But what my advice, if I had to do that, is they need to have at the very first course, and ours would be anatomy and physiology. And then we would introduce the key terminology, and then over the curriculum, map it out. So in the next course, if they're doing, say it was pediatrics, and then I would meet with that instructor and say, can you have a case where there was a pediatric client that had a genetic condition? And then when they move on to their higher level courses, like they may do cardiology, then there's lots of exemplars of cardiology that could have that genetic component to help them build on this knowledge. But it's all about, for these nursing students, it's all about applying it to their practice and seeing the clinical relevancy of it. And I think that's key, is getting the buy-in. And that's what we found, is getting the buy-in. And if you brought a patient that had a genetic condition or had a family member, then that really gets their attention. And I've done that. My other area of expertise is cardiovascular and genomics. So what I do, I've done panels where I had people with genetic heart disease come in and speak to them, or show YouTube videos. I find if you have a video, you know, because I know your class time is so precious, just anything that gives them that real experience, and that'll get buy-in.
Professor Ana Beatriz is already here. Maybe if you would like, you can say something, Ana.
Thank you very much. Yeah, I wrote in the chat there that usually I give some clinical cases for them, and indeed, oncologic examples are the best, because you can talk about like the risk for cancer, or how a patient can respond to certain types of treatment. And with that, we end up talking about pharmacogenetics as well. But this cardiovascular risk is also very interesting. And like, I usually show them my 23andMe test, because I did the 23andMe many years ago. So I usually show them so they can see how it can be used to gather information about disease risk for genetic disease. Thank you very much.
And I found in my...
Can I use your website to show them?
Absolutely, absolutely.
Actually, I did some print screens here, and I already sent to the class. See, guys, I'm watching this very important presentation in an international event, and the scientist is showing how important it is to know genomics in nursing. So I did all of these print screens here, and I sent to my class.
Oh, thank you. And one of the things that I found when I like in my younger years, I did teach medical surgical nursing, and I found if I used the most horrific cases. So when I taught about cardiac and genomics, I used arrhythmogenic right ventricular cardiomyopathy, which is the gene that causes sudden death in young men at age 40. And in Newfoundland, we're the founder population. So we have the highest rate in the world for that. And that's, so I capitalize on things like that, because, you know, they're young, and it's almost, I almost feel like you're entertaining them and to get their attention. So I try to use the most horrific example that I can get. And they go, oh, wow, you know, and then you see, okay, this is really important because.
Thank you very much.
Thank you, all of you, Professor. And one more question from another professor to April Pike. What is the potential impact of genomic education in nursing on patient safety, disease prevention, and the identification of genetic risk factors?
And that's a fantastic question, and we don't know the answer because we have not done evaluation studies. So, I mean, any answer I would give would be anecdotal and based on what I know from the literature about the, and I can come from the lens of the psychosocial impact of genomics. And And we don't really have that data because we're not evaluating nursing interventions.
Exactly.
So I would like to think that, you know, the outcome is there's better support, better safety, better treatment decisions,
Prevention.
but we're not tracking that data, and this is what we need to do.
And another question from the class. What are the challenges and opportunities in adapting genomic education to the needs of diverse nursing students, considering variations in prior knowledge and experiences? In fact, we talked a little bit about that, but if you would like to add something.
One of the challenges is that nursing curriculum is has so much content, is finding the time. But I mean, mapping it out across the curriculum is really important. So like say, starting your anatomy or physiology, and then introduce it again in your pathway, but build on it. And then have courses or in your clinical, have patients with these genetics. So it has to be a curriculum mapping approach, which is what we're moving towards in Canada, is that sort of approach, is mapping it out. So we don't have the policy of infrastructure yet, but we're starting with the Canadian Association of Schools of Nursing. So if they say that nurses must have genomic competencies, then we have a duty to teach it. So we're starting to get there. So this is where the policy research project is really important, because you have to start from the policy and then thread it down.
And making a policy is not easy, because also we have here the health policy resource Sanja. So doing a policy or just starting to develop that is not an easy step. Even to take the steps is not easy one. And what about Professor Ayşegül Kaptanoğlu is already here, the Dean of the Faculty of Health Sciences, and they have, I think, that nursing department. Maybe Professor would like to say something.
Thank you very much. It was a very interesting topic, actually. And nursing is the future century sciences, that will be a future century sciences, because always we will need the health services, the role of health services in the medical healthcare services, even in public health services. Even there is artificial intelligence in our ordinary life. Nursing will be the star light of the science. That's why it was very interesting, and I enjoyed and I appreciate it. Thank you very much.
Thank you very much.
Thank you, Professor. And we are at the end of the session. So we are now to close all of the symposium. If you would like to add something, or if there was any question from the students are there, but I give your contact information to them. So if they would like to ask something, they can send a message, I think, to you. And yes, is there something that would like to add? Because we are now closing the end of the session today.
I just want to say thank you very much. And if anyone's interested in collaborating or research projects, or PhD students, we're open.
Thank you very much, all of you, of being here. And again, I would just like to mention that as we bring this symposium on health and education to close in the new century of the Republic of Turkey, I'm deeply inspired by the collective dedication and passion we have witnessed here today. And the synergy that I see between health and education, I can say that it is the cornerstone of progress of our nation, and the ideas shared here are the seeds of a bright future, I think. So let us carry this momentum forward and embracing innovation and collaboration as we work tirelessly to enhance the well-being and education of our citizens and our all of the people that live in the world. So together we can say that we can forge a path towards a healthier, more educated and prosperous, not only Turkey, but also for the world and for the next generation that are going to come. So thank you to all who have contributed to this symposium success, and let us continue to lead the way in shaping a better tomorrow, a better life, and a better future for the young researchers, academicians, and the students that already are here. Thank you again for being here and sharing your knowledge. Thanks a lot to everybody. I'm closing now.
Thank you. Bye.
Bye. Thank you.
Thank you.